me 1 minute. Yeah, good morning, everyone. We welcome you all on this Valentine's Day, wishing you all a happy Valentine's Day and a very good morning to everyone. We are here with Minimally Invasive Spine Surgeons Associations of Bharath. And to conduct this session, I hand over to our moderator, Dr. Gururaj.
I think, Arvind, you are going to start?
Yeah. So, good morning, everybody. So, welcome you to a happy scientific Valentine Day. I'm sure your wives and girlfriends will be cursing me mostly for organizing this on Valentine's Day early morning. Going seriously. So today, as you know, the discussion will be mainly on anterior MIS pathways. If you go through the history of spine surgery, you realize that change is the only constant thing in life. So the groundbreaking in spine surgery started with posterior approaches. The anterior approaches were popularized by the Hong Kong group when they, in view of tuberculosis. So there was again a significant interest in anterior approaches, anterior reconstruction, etc. The emergence of pedicle screws and the potential power these pedicle screws had, and the discovery of extracavitatory approaches and the ability to shorten the anterior column again revolutionized spine in another way. And again, the interest came back to the posterior approaches, wherein you could achieve anything and everything from behind. It goes to the credit of MIS spine surgeons that there is a renewed interest in anterior approaches due to the concept of indirect decompression that one can achieve from front. You can not only achieve indirect decompression, you can get a better sagittal alignment from the front. So to highlight on this particular concept, we have Dr. Guru moderating the session. He has picked up a bunch of highly specialized MIS spine surgeons who will throw light on the resurgence of anterior approaches using MIS techniques. And at the end of the session, we will have our organizing secretary for MISSAB Surgical Symposium that will be held in Bangalore. He'll highlight on the update with regards to this particular conference. So, Guru, the podium is yours.
Thank you, Arvind. Good morning, everyone. I welcome you all. So our love for the academics has brought us today here on the Valentine's Day. Still, we are sitting in front of our computers. So that goes on to show that we have lots of love towards our academics and teaching. So without wasting much of time, so we'll start with the program. So as usual, like what we have is a journal club first, and our opening batsman will be Dr. Dhruvin Patel. I am sure he will score a double century today like Rohit Sharma did yesterday. He missed on it, but I think Dhruvin will complete it. Dhruvin, I welcome you to present your presentation.
Thank you, Guru. Thank you very much. So my today's article that I reviewed is regarding the comparison of oblique lateral interbody fusion with percutaneous posterior fixation in lateral position and minimal invasive transforaminal lumbar interbody fusion for a degenerative spondylolisthesis group. The article that I reviewed, it was from...
Dhruvin, your screen is not seen.
Just a minute. Now, okay.
We can see your screen, but not the presentation.
Here?
Yes, it's coming up. Yeah, now we can see. Yes.
Okay. So the article that I reviewed is regarding from the Asian Spine Journal, and it's regarding the comparative studies between the OLIF with posterior fixation, but in a lateral position, and MIS TLIF for a degenerative spondylolisthesis. Now here is one article which I reviewed that it's a posterior fixation in a lateral position, but normally, yes, we do turn the patient prone because in my center, we don't have any navigation system to do it in a lateral position. But still, I love this article and I reviewed it. So basically, the study period was from 2013 to 17. And in this particular Japanese hospital, they were doing OLIF since the beginning of 2012. And when they faced certain problem, then they switched over to navigation system as well as lateral position, but with a cortical screw trajectory. But still, the study seems to be important because for a degenerative spondylolisthesis, yes, we do MIS TLIF techniques, but how it comes vis-a-vis OLIF was an interesting aspect. So the study group involved around 50 patients for MIS TLIF, and OLIF was near about 42 patients. And again, for inclusion criteria, it was a classical single level degenerative spondylolisthesis. And what was the criteria for a selection of open decompression? Primarily, they did it for MIS TLIF where there was ossified ligamentum flavum or a very severe stenosis. But they didn't do any open decompression in any case of OLIF cases. What was their study evaluation time? It was a very specific Japanese Orthopedic Association back pain evaluation questionnaire. And that is the JOA BPEQ, which they compared between the MIS TLIF and the OLIF. They also evaluated the residual low back pain, leg pain, and leg numbness also. For radiological assessment, it was a pretty simple evaluation with a disc height and slip angle, although they didn't measure any of the spinopelvic parameters. For a stenosis, classical MRI grading evaluation with a SCISAS method. Regarding the invasiveness of surgery, they did measure operative time, blood loss, as well as C-reactive protein level post-operatively also. The method for evaluation of the disc height is a very standard mid portion of the superior end of the inferior vertebra and the slip angle with the posterior corner of the margin. Surgical technique, as has been described and will be described, it was a standard method as that described. Now, the interesting part for lateral position fixation was that they didn't put the screws by a standard posterolateral approach because they faced a lot of difficulty when they tried to put screws on the right side because of the positioning. So what they did do, they put a cortical bone trajectory screws, but directly in the sagittal plane. I think by that methodology, they were able to put their screws in a lateral position easily. Of course, they did use O-arm and navigation to put their screws, but that could be an interesting aspect to put the screws. And by that method, they were able to avoid the difficulties which they faced in putting the screws from the right side in the lateral position. The technique was pretty similar for a modified cortical bone trajectory screws. It's a straight sagittal plane trajectory with a little bit of angulation in the caudocranial angle. Even for MIS TLIF, they had a little bit of a different aspect. They didn't do MIS TLIF by a bilateral small midline incision, paraspinal incision. Rather, they preferred single midline incision. They dissected right up to the pars, but not the facet joint. Even here also, they put the cortical bone trajectory screws. They do decompression and TLIF from the same aspect. So even there, MIS TLIF technique was a little bit different than what we normally do for MIS TLIF procedure. All this may have contributed to their low C-reactive protein level post-operatively. Here is one example of doing an OLIF radiological. And here is another example of their technique of doing MIS TLIF procedure, where they put cortical bone trajectory screws. The interesting aspect was comparing the results regarding the surgical invasiveness and other aspects. Surgical time was almost similar for both the procedures. The one reason could be that they did their posterior fixation in the same lateral position. So that may have contributed to a surgical time equal for OLIF as well as for MIS TLIF level. Even the estimated blood loss was the same between the two procedures if we take a p-value for them, which was less than 0.01. C-reactive protein, of course, it was a little bit higher for OLIF on the first and the third day, but by fifth day, C-reactive protein level equalizes for both OLIF as well as for MIS TLIF procedures. So that was something interesting, that C-reactive protein was a little bit different for OLIF and MIS TLIF, at least for initial couple of days, but by the fifth day, it's almost the same. Disc height is obviously a little bit higher for OLIF compared to their MIS TLIF procedures. And regarding the sleep angle, it was the same for both the groups. There was not much of a difference as far as sleep angle was concerned. Regarding the important clinical aspect of the results, as far as the back pain was concerned, I think the physical domain was the same between the MIS TLIF and OLIF, whether if you consider it as a back pain or a lumbar function, which are 5 different domains in this particular Japanese Orthopedic Association low back pain questionnaire. Even the social life aspect was also the same. Somehow what they could not explain is the psychological domain of this particular evaluation questionnaire. They found that psychologically patients were much more happier with OLIF compared to the MIS TLIF. And even they couldn't explain why the psychological domain is better compared in in OLIF compared to MIS TLIF. One only explanation they could give was that maybe preoperatively those who underwent MIS TLIF had already higher psychological factor for MIS TLIF, but this is the only finding that they could generate between the comparative studies between the MIS TLIF and OLIF procedure. But as far as low back or a leg pain or a leg numbness is concerned, it's the same for both MIS OLIF, TLIF, or even OLIF procedures. So, I mean, what they ultimately gave was that the comparative data between OLIF and MIS TLIF is the same. As far as the physical function goes, it's only that psychologically OLIF patients had a better score compared to an MIS TLIF. And they didn't do decompression in all the OLIF cases. It was all indirect decompression. It has a comparable outcome. The only drawback was that it was not a randomized study. Evaluation was not very frequent. It was only at the end of 6 months and 1 year, and no spinopelvic parameters were measured. Now, if I apply it in our setup, I mean, for me, it's difficult to do lateral position fixation without O-arm navigation. I mean, I don't have any guidance whatever to do lateral position fixation. I have to turn my patient prone for putting the posterior pedicle screw fixation. Most of our cases are also having very severe to extreme lumbar canal stenosis. Most of them are having scissors grade 3 or 4, where only indirect decompression by OLIF may not be adequate, or even at least we don't feel that it may be adequate. So posterior decompression by open technique during posterior fixation is most of the time required. And many of our geriatric patients are osteoporotic, where chances of subsidence are also pretty high. So that makes posterior fixation mandatory in most of our cases. And if for a single level OLIF, it may be okay, but if I do 2 or more level OLIF, I mean, even if I use a grafton or a DBM with master graft and all that, I definitely require some autogenous bone graft harvesting. And it does give some definitive morbidity from the iliac crest if I do more than 2 or 3 level OLIF. So that is one aspect which I consider it. So it was a small presentation from my side, and that's it. Okay, Guru.
Thank you, Dhruvin. I think that was a wonderful paper. And I would like to ask our guest speaker, Dr. Umesh, to comment on basically the paper. You do have any comments on this?
Yeah, I mean, the selection criteria for patients, these were 2 different set of patients that were patients that needed direct decompression. They did the surgery using TLIF, and then patients who didn't need the decompression, they used OLIF. So different group of patients, and they definitely modified even the posterior fixation. It's tough to compare these 2 group of patients. I mean, if you have to do a good study, at least you do a non-randomized study where you follow patient prospectively. So and then it's a small number of patients, some small group of patients. When you look at the difference between the outcomes, if you have to get a significant difference, you have to have a large number of patients. So those drawbacks are there in the study too.
Ayush, I have seen your some photos. You did some pedicle screw fixations in lateral position. So did you find any difference in your patients?
Yeah, so I think you can do it. We have been doing it for single level, and till now we have not find any difficulty. But what we have done is we have selected a case where we know for sure that pedicles are good. We won't find any problem. We have not gone for a multi-level single position OLIF construct till now, and maybe with time we'll go. So few things like it does have an advantage. Definitely one advantage, you save almost 20 to 30 minutes because you don't have to flip the patient. Again, in cases like this where you have a listhesis and sometimes the facet joints are completely fused, you can work both the ways, especially because sometimes the facets are arthrotic and all. Even if you do indirect decompression, you might not be able to achieve what you want to do, achieve anterior, because posterior elements come into play. And that is one place where I think single level you can work front and back and you can achieve more. Although our indication has not been more than one grade listhesis, but for one grade normally we have not required much of a work anterior posterior. But I think the future, if you either you get used to it doing it or you use navigation. We are doing without navigation with SIAM, but our selection criteria has been very limited, so we have not ventured into really difficult cases. But we feel it does has an advantage, and as you grow doing cases, you should be able to manage a single position OLIF.
Okay, thank you. Anybody else has any comment on this? Anybody else has any experience? Anand?
It is important to have these patients, when you select for single position or indirect decompression, they need to only have foraminal stenosis. If there is any lateral recess stenosis or central stenosis, the surgery does not give enough benefit to the patient, and patients end up needing revision. So in my center, what I do is, even if I have to do percutaneous fixation, I do the OLIF on day 1 and I do the posterior stage on day 2. So in between the stages, I make the patient walk and I get the MRI between stages and see how the foramina look like, how the canal is decompressed. And if they have the symptoms, or if the decompression, the indirect decompression seen on the post-op MRI is not adequate, then I do the direct decompression.
Yeah, I agree with Umesh Metkar because I do multi-level OLIFs and XLIFs. Day 1, multi-level ALIF OLIFs or ALIF or XLIFs or XLIFs. And on day 3, I do it on day 3, not on day 2. Day 3, I do the posterior. I get an EMG. If there is any pain or anything, I get an EMG verified, whether the nerve is still compressed or not, or maybe a scan again, CT and MRI. And then on day 3, while doing the percutaneous screw, we'll do the small decompression over there.
Okay, I think with OLIF and basically the XLIF going out of the vogue and then OLIF be remaining there, and then we are doing more and more these procedures. I think putting pedicle screws in lateral position is going to be a regular thing now. With basically all of us are trying to get worms, so navigation and robots. So I think that was a good paper, Dhruvin. Thank you. And we'll just, for the want of the time, we'll move for the next paper. That's by Dr. Abhinandan Reddy. He is a consultant at Indian Spinal Injury Center. Dr. Abhinandan.
Thank you, sir. I'm sharing my screen. Thank you, MISSAB, for providing me this opportunity. Today, in my presentation on the Journal Club for the MISSAB, carrying forward on the word from Dr. Nayak and Dr. Metkar, there is an interesting study which shows is really posterior decompression required in patients who are undergoing anterior surgery for stenosis. So this is an interesting study in the Journal of Neurosurgery Spine, published in June 2020 by Park and Momaneni et al., regarding the predictors for the need for laminectomy after indirect decompression via initial anterior or lateral lumbar interbody fusion. So despite the power of the interbody fusion, we all know that if indirect decompression alone is enough to completely alleviate the radiculopathy and the claudication symptoms, because in the literature, the posterior laminectomy after anterior procedure has been reported to vary up to 60%. And the efficacy of indirect decompression is still questionable, and there are no clear-cut guidelines. And the radiographic and clinical outcomes studies regarding these indirect decompression of central canal stenosis are not many, and there is very little data regarding the efficacy. So the purpose of this study was to evaluate the factors that are associated with the need for additional posterior indirect decompression after ALIF and lateral lumbar interbody fusion. So in the methodology, this is a retrospective study in a single center North American spine center, and this was done during January 2010 to August 2017. And all the patients who underwent 1 to 3 levels of anterior procedures were enrolled, and the surgical indications were classical of symptoms of leg pain, leg numbness, and neurogenic claudication, and with severe low back pain. All the patients initially underwent anterior procedure on day 1 and were allowed to recover in the hospital as inpatients and allowed to ambulate. And subsequently, the second stage of the procedure was done. And the exclusion criteria included patients with adult deformity, infection, fracture, tumor, and prior lumbar surgery, and patients with neurological deficits, and cases in which direct posterior decompression was pre-planned. And the criteria included post-operative VAS score for the leg pain, the back pain, and patients who were assessed and the decompression was not performed when the leg pain improved more than 50% of the initial anterior procedure. Sex, age, duration of symptoms, VAS, and number of fusion levels, cage height, cage lordosis were also recorded in the study. In the radiographic evaluation, they have described the disc height as an average of anterior and posterior disc height, and central canal stenosis as the central canal diameter measured in the mid-sagittal plane at the mid-level of the disc height, and the foraminal height was described as the measurement on the sagittal X-ray from inferior pedicle to the superior border of the pedicle, and the foraminal area was determined on PACS. In the results, they have included 86 patients, and the 62 patients underwent additional posterior decompression during this second stage, and only 24 patients had no posterior decompression in this study. And in this decompression group, the mean duration between the first and second surgery was nearly 3 days, and it was nearly the same in the non-decompression group too. As we see in the demographic characteristics, all the patients were nearly similar except for the symptom duration, where you see it is 14 months in the decompression group and 10 months in the non-decompression group, which was significant. And for the VAS score for the leg pain, it was significant when compared between the two groups, as the patients with decompression had a longer duration of and increased VAS. And procedure-related factors, the number of fusion levels in decompression group was much more when compared to the non-decompression group, and there was no significant difference when we came to cage height and cage angulation in the present study. And the preoperative radiographic measurements were nearly the similar in the decompression on the non-decompression group regarding the disc height, foraminal height, foraminal area, central canal, and the facet joint degeneration. But when we come to the postoperative radiographic measurements, there was a significant value when compared to the decompression on the non-decompression group in the percentage change in the disc height, percentage change in the foraminal height, and the foraminal area when compared in the decompression and the non-decompression group. So in the literature, we see that immobile facets, osteophytes in the lateral recess, calcified discs, and osteophytes arising from the posterior end plate as the reasons that indirect decompression alone may not be sufficient. And in this study, there were 62 patients who underwent additional posterior direct decompression. So what is interesting in this study was that there was no significant difference in the preoperative central canal diameter between the two groups. Thus, the radiographic central canal stenosis alone did not appear to lead to bias towards decompression. And regarding the patient-related factors, the duration of symptoms were longer in the decompression group and the VAS score was high in the decompression group. So this shows that patients' clinical symptoms and history are very much important. And in also addition, the mean number of fusion levels was higher in the decompression group, which shows that multi-level stenosis may have had such severe symptoms that it was difficult to localize the exact level of the pain. And cage height and cage lordosis did not affect the post-operative clinical outcomes. And what is important is direct comparison of cage heights, but rather than difference between the cage height and preoperative disc height. This may correspond to an increase in the foraminal height and foraminal area, which we gain through anterior procedures. This study has few limitations, being a retrospective and a single institution, and it dates as back as 2010, where still indirect decompression alone was not a norm. And there could be a selection bias for laminectomy in many patients based on radiographic findings, and the numbers are too small to determine. In conclusion, they said that in the selected patients, indirect decompression without direct decompression may be a reasonable option in treating degenerative spinal conditions. And the change in disc height from its preoperative state provides greatest radiographic change and is potentially a reason that posterior decompression is not needed in certain patients. So this study, I think, has few drawbacks because the present study does not measure central canal stenosis in an axial measurements where the central canal area must be measured. In this study, rather on the sagittal plane, they have measured this central canal diameter, which does not exactly give the picture of the central stenosis. And also, majority of the adult degenerative patients have adult deformity to some extent, which has been excluded in this study. And few functional scores have been excluded in the present study. So the present study shows that indirect decompression can be a good tool in the armamentarium, but not exactly where indirect decompression is only sufficient is still uncertain.
Thank you, Abhinandan. That's a very interesting paper. So I would invite Dr. Umesh Rikanta to have a comment on this paper.
Yeah, thank you, Guru. So the outcomes that have come out of this study are pretty well, I think, were known to us. In the case like even in indirect decompression, we know that it is not just the radiological factors that matter, but the clinical factors as well. We see patients who we have gotten post-op MRI for after an indirect decompression where there is still persistent compression according to us, but the patients are doing fine. And there are cases who, even otherwise, like say, for example, even if we go back to non-OLIF cases or non-decompression cases, we see a lot of elderly patient population who have significant canal stenosis on MRIs radiographically, but clinically they are perfectly fine. And we have other group of patients who have only mild or moderate lateral recess stenosis, but to exhibit significant claudication symptoms. So there is something dynamic that is going on in the sense like in lumbar canal stenosis, where there is no correlation always between what we see radiologically and what symptoms the patients experience. And basically the outcome of this study, what we have to take a message from this study is similar. So we can't base our decision of whether our indirect decompression has been adequate for that particular patient or not based on radiological factors alone. Coming to the application of this, I think there is a significant block as far as in Indian population goes, because most of our patients are not ready for a two-stage surgery. So that is where application of this concept is going to be significantly hindered. Means I think over a period of time we have to find out reasons where or find out criteria where indirect decompression alone may be sufficient, or patients who require an additional decompression. And I think we need to just refine our criteria. One factor that we consider when choosing whether additional decompression is required or not is basically whether patient has a rest-related symptoms or whether patient has only dynamic symptoms. So as long as patient has only dynamic symptoms, that is like patients are relatively comfortable while sitting or while lying down, and they develop symptoms only on standing and walking. These are the patients who benefit best with indirect decompression alone. Whereas patients who develop significant radicular symptoms even at rest, probably they have rest pathology as well. And these are the cases who may require an additional posterior decompression. This is just a very broad criteria. It's not like a very strict criteria, but this is something that may guide us to select cases which require an additional indirect decompression.
Thank you, Umesh. I go to Dr. Umesh Metkar. So I just want to ask one thing. What are your indications for additional posterior decompression when you do OLIFs in your these degenerative cases?
So I strictly reserve for the indirect decompression if there is only foraminal stenosis. If there is any, most of these patients have grade 1 or grade 2 spondylolisthesis, and if there is only foraminal stenosis without significant lateral stenosis, then I would consider indirect decompression. But when I do that, preoperatively I ask them questions before taking the patient to the OR. I ask them the question, which leg hurts more and when the symptoms are. So and then just before the next stage also, I ask them the same question. So I make them walk between the stages, and I get an MRI for every single anterior posterior patient. And then I look at the foraminal height. If the foraminal height is restored, if the nerve root is free and a T1 weighted sagittal images, and the patient doesn't have symptoms, then I just do percutaneous screw fixation. If they still have symptoms, then what I usually do is I still do a MIS approach. We'll see approach and do a far lateral decompression. And usually patients who are elderly who have osteophytes, bony osteophytes, when there are osteophytes more than just a disc bulge, those patients do need direct decompression, because even if you restore the disc height, that osteophyte will still take the nerve, it will still end up compressing the nerve because it's moving with the upper vertebra. It's not going to go away anywhere. It's the disc bulge, a soft disc bulge is what usually would get better with indirect decompression. So it's important to look at the preoperative CT scan also, what kind of foraminal stenosis these patients have.
But but that would, Dr. Umesh, that would mean, so for example, if it is a L4, L5 stenosis, the most common scenario is a lateral recess stenosis. So that, majority of times you hardly get a foraminal compression at, hitting the L4 root. So that will be a very small subset of patients where you do OLIF, that means.
Well, not really.
He was talking about foraminal stenosis, where
I think. Oh, I'm sorry.
Those are the patients I decide for indirect decompression. If there is foraminal stenosis with lateral recess stenosis, then I would do the direct decompression. So next day I would still do the
the foraminal stenosis group would be a very small percentage of patients. So generally, when you do L4, L5, when you think of L4, L5 stenosis, it is generally the L5 root in the lateral recess that we are concerned about. L4 root involvement is not very common, for the foramen to compress, to narrow down and hit the L4 root is a very small percentage of patients.
Exactly.
So that will narrow down the number of cases that you would do for a L4-5 problem.
Exactly. So here it's so common that people project that, oh, I do everything just with the indirect decompression. A lot of surgeons are very aggressive too, so they just do it for like a small, very little foraminal stenosis that doesn't even need decompression. So actually speaking, the subset of patients who really are eligible for indirect decompression is very small. I completely agree with that, and I don't offer it to every patient. And other set of patients.
So this comes with the hidden agenda, indirect decompression with fusion, that the with fusion goes into the bracket, it gets hidden away somewhere.
So
and
go ahead.
One thing the indirect decompression is the best is for lytic spondylolisthesis. Those patients, are the best candidates for indirect decompression because they don't have the bony stenosis that other patients have at the foramen. Their main issue is the antrolisthesis, and the remnant of the parts that goes forward with the with the listis vertebra that gets restored with the anterior procedure, and those patients benefit with indirect decompression. So I rarely have to do direct decompression for those patients. Those really benefit from indirect decompression.
Okay, thank you. Actually, I know where Arvind is going. I think Dr. Umesh Srikanta wanted to have a counter for that. So go ahead, Umesh, in just few seconds.
I think part of the question has already been answered. So what I wanted to mention is that it is not just the subset of foraminal stenosis that are eligible for an indirect decompression. I feel that there is a significant proportion of even lateral recess stenosis without any foraminal stenosis who can benefit from an OLIF procedure. And these are the patients who have, she has 2 or 3 grade lateral recess stenosis, along with dynamic symptoms, who do not have symptoms at rest, who develop symptoms only while walking, and who have at least a little bit amount of a disc space reduction. So these are the patients who are going to benefit by achieving the disc space distraction. We are just reducing the bulging annulus and we are stretching the ligament within the lateral recess. And these patients who do not have that medial superior articular process hypertrophy, that bony stenosis that is there in the lateral recess overlying the nerve root, that medial lip of the superior articular process, who do not have this kind of bony stenosis, these patients actually develop benefit significantly with an indirect decompression, even if their symptoms are related to just a traversing root compression.
Thank you.
And
so, go ahead.
And that's where the duration of symptoms come in. If the patients have long-standing duration of symptoms, that means that eventually whatever their soft osteophytes or ligamental hypertrophy was, that becomes calcified, and that those patients usually need direct decompression as compared to getting better with indirect decompression.
Thank you. For the want of the time, we'll move ahead. Jala sir, I will come back to this point maybe in later talks. So just be there. And just next talk will be by our rising star, Dr. Ayush Sharma. He's practicing at Central.
Yeah, sorry. Just one announcement. So for those on Ortho TV, if you have any questions to be asked, so there is a Q&A box. You can type in your questions there and I'll address it to the concerned speakers. Thank you.
So I would like to invite Dr. Ayush Sharma. He is practicing at Central Railway Hospital, Mumbai. He's our rising star. Ayush, his topic is applied anatomy of MIS approach to anterior lumbar spine. Over to you, Ayush.
So thank you, MISSAB, and thank you, Gururaj, for the opportunity. So I think this is the most important thing before you start minimally invasive spine surgery. We all are familiar with PLIF and TLIF approach, but today we are talking about XLIF, OLIF, and ALIF. And if you see in the anterior, you see some funny things coming up, and it sometimes can make you scared because it looks very simple from posterior. So let's understand and get out of the fear of these unknown identity which are in the anterior. So I will be talking on anterior approach applied anatomy. Now, the anterior approach is nothing new. It has been there for almost 90 years. 1932 was the first time when this started with ALIF. It was from the University of Michigan for spondylolisthesis. And almost 10 years later, this was from the Hong Kong group in 1944, where they started for tuberculosis, the lateral approaches. And then we have came a long way, and last 20 years has been very, very interesting because we have gone through minimally invasive. And now we have 3 different approaches when it comes to approaching the anterior lumbar spine. We have ALIF, we have OLIF, and we have direct lateral approaches. Now, if you see this, the ALIF and OLIF, they go through a natural corridor. We have a natural corridor to exploit. When we talk about the direct lateral or the XLIF, it goes through the Swash muscles. Now, Swash muscle is not a muscle. It is a harbor of some very, very important nerves. And some of these nerves, this is the cadaveric dissection you can see when the swash has been taken out. And this can be as thick as 2 centimeters. So there is a plethora of nerves which goes through these lateral approaches. And that is important to understand before you venture into it. And it is specific at each and every level. So for example, for L1, L2, it doesn't matter much. We don't have much coming here. But as you go down L2, L3, your genital femoral, ilioinguinal nerves, again 3, 4 genital femoral, again 4, 5 obturator and femoral nerves. So while the direct lateral approaches, you are going through the muscle. So it becomes very, very important for you to make sure that you are not damaging any of these nerves, important nerves which are coming in. When it comes to oblique approaches, which is the OLIF approach or ATP approach, we go through an oblique corridor and we try to avoid the swash and these nerves which are harboring there. So this is again a very, very important diagram. So basically this is based on the cadaveric studies, and they have tried to mark the nerves intraoperatively by using the dye. And this gives a footprint of OLIF versus a DLIF. So this is the footprint of DLIF, which is the direct lateral approach. And this is the footprint of OLIF. If you can see, in most of the cases, it again at L2, 3, and maybe if you're going L1, 2, it won't matter much whether you're going into a direct lateral approach or an oblique approach. But especially when if you come down to 3, 4, and 4, 5, it does appear that if you're doing a direct lateral approach, you're more likely to encounter some important nerves out there compared to a OLIF approach. Now, again, if you're planning to do a oblique approach, the trajectory of attack is very, very important. There's a famous story of the Boeing MAX 747. It could not maintain the trajectory of attack, and this happened. Similarly, OLIF has a very, very important trajectory of attack, which is between the swash and the aorta. And for each and every case which you want to do, you should go through the preoperative and MRI and understand that you should have a decent window of trajectory of attack before you venture into it. Now, again, not only that, you need to study the anatomy and correlate it with the MRI finding. You have to look at the bifurcation of the aorta. For example, if there is a bifurcation, as you can see here, is coming high up, then your arteries, the bifurcated arteries will be sitting exactly where you want it to be in the oblique approaches. And these small applied anatomy is very important. Again, another very important and very notorious thing is this ilio-lumbar vein. Now the ilio-lumbar vein, it after bifurcation, it goes up and goes and then goes quite posteriorly. But if you have a transitional anatomy like a high bifurcation, it can come right at the L4-5 disc level. And these are valveless vein, and that could mean a disastrous intraoperatively. So these small anatomy you should understand. You should try to correlate with the MRI findings. When it comes to the approach of OLIF, we go or the XLIF, the approach is the same. Only difference is you go through an oblique corridor when you're doing a OLIF, and you go through the direct corridor and direct approach when you're doing the direct lateral approaches. Just a small video to show you the muscle and the anatomy. This is intraoperative video. After once you have cut the skin, the first layer will be the fascia, and then comes the external oblique muscle. Now these layers will remain the same whether you are doing a direct approach or a oblique approach. And as you can see in the video, each and every layer is a distinct layer, and you can understand we are going from one layer to other, but just by looking at the change in direction of the muscle. We have just split the external oblique muscle, and you can see the change in the direction when it's the internal oblique. So even if you don't remember the layers, you just need to keep going, keep splitting the muscle as they crisscross each other. And one of the beautiful thing which I like about the anterior approaches is that if you see, we are not cutting anything, or we are just splitting a natural corridor, and which is there to be exploited. Then the transverse abdominis, and then this is the fascia transversalis, and this is a very, very thin flimsy layer. And you can see, if you look careful, you can see the change in the color, which tells you where you are. Fascia transversalis can be almost very thin or sometimes negligible. So it is very important that you can do this with just a finger dissection, and you can just take swipe the fascia transversalis, and along with the next, you'll get the retroperitoneal fat, and this is the time when you know that you are near the peritoneum. And then you need to be careful not to damage it, and you can swipe it using a small gauge piece or something like that. The next is what you get is the Swash muscles, and that is where you know you are near the corridor. And you just, once you swipe the Swash muscle, you'll get this space, and this is your working corridor. So this was the trajectory which we took. And if you're doing direct lateral, indirectly on the instead of going in this area. This is important that if you're going oblique, you need to swipe the peritoneum anteriorly so that you can end in this junction. When it comes to ALIF, again, the most of the anatomy is the same, but you go lower down either at the L4 and L5. And what you do is, we know that all these muscles which we just saw, they make the central band, which is the rectus sheath. And in ALIF, you cut the rectus sheath at the lateral border, and then you swipe everything through the retroperitoneal approach to end up between the aorta and the Swash muscle. And Dr. Anand will be talking more about it. Again, when it comes to ALIF, one need to understand the bifurcation before you go ahead and try to do a ALIF, because the bifurcation could be high or low. If the bifurcation is at a higher level, it does help you to do a ALIF more than maybe a OLIF or a DLIF. And you can even go up to L4, 5, and depending upon how the anatomy is. So understanding the anatomy before you do the anterior approaches is one of the most important things. I'll just show you two videos why this applied anatomy is very, very important. These are two intraoperative videos. So this is a case where we have just completed the steps of dissection, and the Swash has come in. We use this self-handling retractor. They are oblique retractor. They are over round semicircular retractor. These are our own personalized retractor to see everything before we go for the surgery. Now, if you see, this is the Swash, and you can see just on the anterior border of the Swash, we are seeing a thick nerve, which is the genital femoral nerve. This is exactly where ideally we like to talk about retractor. So this nerve is just coming. It is a very, very thick nerve, and you need to understand these things before you venture into the anatomy. Now, in this particular case, what we could do is we could use this nerve retractors, and they are deep nerve, and swipe everything. So everything, including the Swash and the genital femoral nerve, goes completely out of our way. We can see everything, that we don't have anything underneath, and under complete vision, we will dock our first retractor. So understanding this anatomy, you cannot go blindly, and what we prefer is to do everything under vision, and then we dock the other retractors. Again, this is a very, very interesting case. So this was at L4, 5 level. If you can see, already my cage has gone in, and it was maybe we were trying to put a very, very big cage. I think it was 16 mm cage. So while putting the cage, we had to really distract quite that much, because you need that gap to do the orthogonal maneuver. And everything went fine. The moment I closed the retractor, I saw a gush of blood coming out. So we have to again open everything. If you can see, this is the bifurcation. And if you understand the anatomy, this is the iliolumbar vein which is coming out here, and we're just trying to find out where that gush of blood came from. Just then, I'm just trying to see anything we have damaged or anything, and so this is the iliolumbar vein. We're trying to distract you. that just clipping. See how much it can be really frightening situation if you don't understand the anatomy, especially if you are looking for a tube. So everything comes filling in. We are just packing. Fortunately, because it was a iliolumbar vein, we could identify it, and using the neurovascular clips, we could just clip it. And then we also called the neurovascular surgeon to make sure that nothing else was there. So that understanding of the anatomy and realization of where we are really saved the day for us. Otherwise, it could be, and this everything, fortunately, we could do through still using the tube. So at the end, I like to conclude that good understanding of applied anatomy is a must. Not only that, you have to correlate this with the radiographic anatomy based on the MRI, CT, and combining both these. When you're doing anterior approach, you should have a three-dimensional awareness of your anatomy, and that will really help you do a better job and to reduce your complications. Thank you so much.
Thank you, Ayush. That was a very nice presentation. So that sets the ball rolling. And I would like to call our next speaker, Dr. Neeraj Vasavda. He's practicing spine surgeon at Ahmedabad. He will speak on ALIF, XLIF, OLIF, when and why. Dr. Neeraj?
Yes, Guru. Give me a sec. I'll just share my screen. Okay, so can you see my screen here?
Yes, Neeraj. Yeah.
Okay, so I think Ayush has already made the opening statement, just like Rohit Sharma did yesterday. So we are here to talk on why, when, and when not to do this anterior approaches. So these are the routine cases we do see in our day-to-day practice. And most of the time, the fusion, rubber fusion, is the surgery of choice for these cases. As Ayush already mentioned, there are multiple ways to deal and bell the cat. So we start from P-LIF to T-LIF to X-LIFs or LLIFs or OLIFs or A-LIFs. There are multiple things to tackle this. So we are going to basically focus on three procedures today. That is D-LIF, or we can call it an X-LIF or LLIF, the OLIFs or anterior to psoas approaches, and the A-LIF, which probably Anand is going to talk on much more detail. And you can see that all three has different trajectories to be used. So before we talk and compare that, why we should be using these techniques, what are the ideal surgical techniques, any ideal surgical technique? So it has to be having a better or a comparable result with the gold standard, which is a T-LIF, open T-LIF over here, or a MIS T-LIF nowadays. No unsurmountable learning curve. It has to be an easy to operate. A reproducible, persistently reproducible result should be there. Acceptable complication profile as compared to gold standard, and it has to be affordable, specifically in our Indian context. And when we are dealing with lumbar spine these days, the lordotic angle, the restoration of lordos, is another very important thing before we decide that what should be the ideal surgical technique. So before we begin, I think I would want to directly compare head-on-head with MIS T-LIF and the anterior approach. In this case, it is the OLIF, and let's see then which surgery scores over. And I would like to quote here a Korean paper by Professor Jin Sung-Luk Kim, and they have compared a matched cohort between OLIFs and T-LIFs, and they have compared different parameters, right from operative time to blood loss to various things. And let's take one by one. So if we compare with OLIF and T-LIF, MIS T-LIF, the operative time was much lesser with OLIFs or anterior approaches. Estimated blood loss was significantly less with OLIF, but the hospital stay was more or less equal without a significant p-value. If we look at the ODI, even at the last follow-up, that is, almost beyond 12 months, the ODI remained persistently good, whether you operate anterior approaches or a posterior approaches with MIS T-LIF, and they both were same. Similarly for VAS and VAS pain, VAS for back pain and leg pain, they were also same. So this is very important, though it is same. There are some proponents or opponents of this anterior approaches who don't believe in indirect decompression. They are literally afraid about adequate decompression with this indirect approaches. And this slides over a period of time proves that it's probably not good founded, and OLIF gives equally good result as the posterior approaches. The disc height was significantly better with anterior approaches, and foraminal height also was restored much better. The most interesting part is the segmental lordosis was much better with OLIF, while the overall lumbar lordosis remained more or less equal. Now, this is another very important slide, that only at 6 months, if you see the anterior approaches as compared to posterior approaches, achieved significant as far as we'll talk about fusion. But the important thing is that 6 months, the 80% of anterior approach patient had fused, while only 52% had fused in posterior approaches. So anterior approaches, whether it is an OLIF, whether it is an LLIF, or whether it is an ALIF, provides early fusion and may prevent complication due to delayed fusion of the our cases. If we look at the individual segmental lordosis, disc height, and even at alpha S1, the OLIF scores much better. The anterior approach is scores much better as far as the segmental lordosis is concerned. But at alpha S1, only ALIF is the technique which gives a very significantly better lordosis as compared to posterior technique. So when we compare head to head, whether OLIF and MIS TLIF, the OLIF has better or comparable results, the answer would be yes. Whether it has not a very steep learning curve, answer would be yes. It gives us a reproducible result. It is equally affordable as compared to MIS TLIF. Whether it has an acceptable complication profile or not, I would want to quickly take you through some of the complications which we can encounter during anterior approaches. These are the list of approach related complications, out of which we are most likely more worried about the vascular injuries, transient or permanent urologic injuries, and the subsidence. And in ALIF cases, probably the retrograde ejaculation. The other important thing which comes in our way while deciding which approach is better is anatomical restraints or constraints like high iliac crest or a high 12th rib in our patients. Positioning may lead to issues in specifically in LLIF. And there was a cadaveric study done that when you break a table, the left side of image shows the femoral nerve, and it shows quite in a relaxed in non-break position of a table, and it is significantly stretched when you break a table, and this may lead to apraxia, which is not found in OLIF, ALIF, or posterior approach. So LLIF has an inherent risk to damage the lumbar plexus. Approach related complication may be there, like the subcutaneous nerve may get injured, like iliohypogrestic, ilioinguinal nerves, the lumbar fractures, genitofemoral femoral nerve, segmental injuries, vascular injuries. So all these injuries are listed, but if you do a careful surgery, these complications are not very common. Ureter and bowel injury is probably, would say that neglect during surgery, and most likely should not happen in our patients. The nerve injuries in subcutaneous plane may lead to pseudo hernia, which is also not a major problem. When we are doing LLIF, as Ayush mentioned, the anatomical structure which we should be afraid about, which is not there in posterior, are the lumbar plexus. And if you look at this image, there are 4 zones where we can probably dock our tubes in anterior approaches, specifically anterolateral approaches, and only the zone between zone 2 and zone 3 we can find a safe approach. As you come from above downwards, the safe zone, which is a green, narrows down, and it is probably the narrowest at the L4-5 level. The safe working zone is encroached anteriorly at L4-5 level by vascular structure, and posteriorly by the nervous structure, specifically the femoral nerve. If you look at this structure, it again confirms that L4-5 is the most critical level to be operated around LLIF, and that's why we have to use a neuromonitoring in this case, which is again not required in posterior approaches. And when you do an OLIF or ALIF, again you don't require a neuromonitoring. Neuromonitoring is an added instrument, added technique which you might have to use during LLIFs or XLIF. So why we should be using minimal invasive anterior or lateral approaches when we have so much of probably scary complication, although lesser in incidence? So the positioning on table is much less traumatic as compared to posterior approaches, and access for anesthetist is much better when your patient is either in anterior position, supine position, or a lateral position. It is a muscle sparing approach. However minimal invasive you do in posterior, there are chances of muscle damage. Even with endoscopic approaches, muscle damages has been reported. The direct access to disc space visualization with anterior approaches, better anterior release, and this is very important when you are dealing with deformity cases. The vertebral posterior arch, muscles and ligaments are left intact with this anterior approaches. There is no mobilization of dural sac or roots, and which leads to much less chance of root lesion, dural breach, or intracanal fibrosis. Thorough discectomy, which leads to a better fusion, and as we have already seen that it fuses a segment much earlier than posterior approaches. We can insert a very large cage with better surface area for fusion, a better lordosis, and we can even put a large hyperlordotic cage to correct our deformities. The cage are introduced through convex side of the interbody space, enabling much better restoration of coronal and sagittal profile. The infection rates are much lower as compared to posterior, even with comparison with MIS TLIF. ALIF has a distinct advantage when we compare it with LLIF and TLIF group. ALIF has significantly better lordosis as compared to either LLIF or a TLIF group. ALIF and ALIF both restore significant disc height, and rest of the things more or less are similar. The major worry about ALIF comes from retrograde ejaculation, but a carefully performed ALIF has very less chance of retrograde ejaculation. It will be taken by Dr. Anand, and he will make sure that retrograde ejaculation doesn't happen in male patients. As you can see that the cage size between all these three techniques, probably the least amount of OLIF, the size would be in posterior, then next would be OLIF, then LLIF, and the largest size of cage you can put is with ALIF. So this is a summary of the different approaches. The ALIF mainly targets L4-5, L5-S1, L2-3, 3-4 can be approached, but you would require extensive vascular dissection. Probably you would require a approach surgeon. LLIF can be performed from T12 to L5. L5-S1 is precluded for XLIF. OLIF is from L1 to S1. L5-S1 probably requires additional training and better equipment sets. If we look at the risk, ALIF has a 3% vascular injury rate, only 2% retrograde ejaculation rate. LLIF and OLIF is much safer. They may have experienced transient neurological issues, but permanent complications are much lesser in this LLIF or OLIF technique. There are some contraindications when we are deciding upon this anterior approaches. It is an unfamiliar approach, so you should not be attempting if you are not aware about approaches specifically for ALIF. Use approach surgeon. Calcified aorta, prior vascular surgeries, prior abdominal surgeries, history of PIDs, the inflammatory diseases, and any prior anterior surgery are contraindications to use these approaches. Many times we do get kind of patients where posterior decompression is must, like this patient had a facet cyst and you would want to decompress it physically. And in those cases, you may use this anterior approaches, but when you already have to decompress, you have to judiciously select between MIS TLIF or the ALIF approach. You may encounter cases like this when there is an osteophyte compressing over the root and patient has a radiculopathy or a large central disc where you would want to decompress your patient posteriorly. At those cases, you might want to use your posterior approaches over the anterior approaches. The question comes always is, does indirect decompression actually provide adequate decompression? To quote this, I'm putting one of our case, which has a much tight stenosis, almost C or D. And you can see the beautiful decompression can be achieved following indirect decompression without entering posteriorly into the canal. You can see that, this canal is completely decompressed post anterior procedure. The another critical argument comes is a staged procedure. Generally, staged procedure are being used when you are doing a deformity correction surgery. And most of the time these days, the surgeon prefers Dr. Neil Anand's protocol, where he operates stage 1 and stage 2 is left for the second part after a couple of days after taking a proper radiograph. And they have a protocol where if post first stage, that is anterior cage insertion, if your SVA is less than 5 centimeter, you just do MIS TLIF if at all needed. Otherwise, you don't need to just put the screw and come out. If your SVA is further in front, like 5 to 10 moderate SVA, then you would want to use your percutaneous screw with a better bend rod and try to correct the lordosis. But if your SVA is still quite off, more than 10 centimeters, then you would want to do a posterior open surgery. So the basic thing would be that when you do a stage surgery, the blood loss, stay time, anesthesia time are much higher with the second stage, but it gives a better lordotic profile, a better sagittal or a coronal deformity correction. So stage 2-stage protocol is generally for deformity, not for our single or double level cases. At the comparison with MIS TLIF, it is a single stage procedure when you are dealing with deformity, and a properly performed MIS TLIF also gives a better lordosis even at L5S1 when you do a proper release. The only issue would be that you would be doing a large incision. You might be wanting to do a multiple step incision, which can be done with anterior approach with multiple small stabs in your flank, and you can get away doing a large deformity correction. Something like this, just from around 2 inches anterior cut, you can do a 3 cage insertion and just small cuts posteriorly to do your cases. So in nutshell, the anterior or lateral, when you compare, anterior has a better lordosis, better SVA correction, better coronal Cobb's correction, better fusion. PJKs and PJFs are still, the jury is out. However, Anand Group is again coming out with a paper, and they have concluded that the PJKs and PJFs are much lesser, even if when you stop at L1 with anterior approaches. The complication profile, there are major, but the incidence is much less. Cost would be slightly higher when you do a multi-level disorders. It may require anterior approaches, may require a stage procedure, and it is an indirect decompression. So the right indication for anterior approaches are narrower the disc space, better would be better post-operative profile for your patient. Higher loss of lumbar lordosis can be restored with anterior approaches. Modic type 1, Modic type 2 cases are better suited for anterior approaches. Asymmetric degeneration and lateral olisthesis are also much better tackled anteriorly than posteriorly. The wrong indication would be deformity with preserved disc height with stenotic radiculopathy, which would require a posterior decompression, and anterior approach may not be chosen in this kind of cases. Chronic and pure back pain patient with preserved disc height without molding changes are a wrong indication for as such a fusion surgery. So in nutshell, along with ischemic spondylolisthesis or a scoliosis dislocation, loss of disc height and segmental lordosis with or without degenerative spondylolisthesis and modic 1 discopathy are the best indication for anterior lumbar fusions. Let us take at comparative level-wise indication which are better. L5S1 ALIF is preferred method for discogenic low back pain with better lordosis restoration. PLIF or TLIF for a posterior approach is a reasonable method. OLIF has shown promises, and LLIF is not suitable for L5S1. For 4-5, PLIF, TLIF for posterior approaches are good option for degenerative cases. ALIF, OLIF or LLIF are reasonable options for lordosis and deformity correction. Increased risk of lumbar plexus or psoas injury goes with the LLIF. L2-3 and 3-4, all techniques are good except ALIF. ALIF still can be performed, but you would want a vascular surgeon to help you out to mobilize the vascular structures. For deformity correction, LLIF and OLIF is a better option. T12L1 again goes to LLIF. OLIF is not possible in many of the cases. Even in L1-2, when you have an high overhanging T12 rib, you would want to cut the rib to do an OLIF. So LLIF is a better option for this. ALIF is absolutely not suitable for these cases. Multi-level deformity correction, the anterior approaches scores much better over posterior approaches. So this is my final slide. We all welcome you for 9th and 10th MISSAB Surgical Symposium. Thank you for tolerating a long talk. Thank you so much.
Thank you, Neeraj. That's actually an extensive talk, and you covered it very well. I think for the want of the time, we'll move to the next talk by Dr. Umesh Rikanta. That is role of neuromonitoring in anterior lumbar surgeries. I welcome Dr. Umesh.
Yeah, thank you, MISSAB. Thank you, Guru, Dr. Arvind. First of all, I would like to say at the outset that we are not the primary persons who are specialists in intraoperative neuromonitoring. So we always take the help of a qualified neurophysiologist for doing our intraoperative neuromonitoring during anterior or any kind of spine surgeries. But of course, it is very important as a surgeon to know the basics of the monitoring techniques that are available and its applications for especially for anterior and lateral approaches. So we know that there are three main techniques for an anterior or lateral access spine surgery. And, as far as ALIF and OLIF are concerned, the neuromonitoring plays a relatively lesser role as compared to the anatomy and the knowledge of handling vascular complications. Whereas for a trans-psoas approaches, as we all know, because we go through the psoas muscle which harbors the lumbar plexus, it is very important to know the neural anatomy, and it's very important to have neuromonitoring on a standby, which is actually an integral part of a trans-psoas approaches. So why for lateral lumbar approaches, obviously for obvious reasons due to the anatomical factors, neuromonitoring becomes an absolute necessity. It is because of the major nerves which Dr. Ayush has already stressed upon, that traverse through the psoas muscle, especially at L4-5, where they come as anterior as to the middle of the disc, where your obturator or the femoral nerves are at a higher risk of injury, either due to direct injury while dilatation or due to the pressure against the L5 transverse process, as we are going to see. So we all know this plexus, brachial plexus, and we have memorized it time and again during our MBBS days. But what we are, were not familiar is with the forgotten plexus, that is the lumbosacral plexus or the lumbar plexus, which is more important as far as the lateral lumbar approaches are concerned. And as we know, this plexus is formed from T-tail to L5. I will not be going into details. And significantly important nerves that supply the groin, that supply the thigh, as well as the muscles in the lower limb are arising from this particular plexus. One most important nerves, some of them are iliohypogastric and ilioinguinal, which are not important as far as the psoas approach is concerned, but they can be encountered during muscle dissections in the superficial layers. The genitofemoral nerve is almost always seen on the surface of the psoas muscle at the level of L3-4 and L4-5. The lateral femoral cutaneous nerve, especially if we are doing a posterior most approach in a very lean individual where the fat is less, we can see that on the surface of the quadratus lumborum in the lateral aspect, at the level of L3-4 and L4-5, and even downwards, even lower below where it courses more laterally. Femoral and obturator are buried within the psoas muscle. Usually they are not seen by direct visualization. Of course, their presence can be detected by intraoperative neuromonitoring. And we'll not go into details about each of the muscle supplies and all those things. I think this was the point that I've already stressed about. And why neuromonitoring becomes important is because of the relationship of these nerves to the center of the disc. So even if we want to put a cage ideally in the center of the disc space for when we are approaching from a lateral approach, so we can see that the nerves are very close to the center of the disc at each levels, and especially at L4-5, where the nerve may be actually traversing through the center of the disc, and that is why it is very important to be anterior to the center at least at L4-5 level. And not only that direct injury due to the dilatation or due to the retractors or due to the probes that we use during trans-psoas approaches, but also because of sequential dilatation and expanding this retractor, the nerve can get stretched and especially compressed against the L5 transverse process. So this is the one that can happen and can result in injury. And we know that trans-psoas approaches were associated with a significant amount of hip flexion weakness, that is a motor weakness. Part of the motor weakness was also attributed to splitting the psoas muscle and an edematous reaction in the muscle, and not always due to the nerve injury per se. Of course, what is more bothersome was the sensory symptoms, which probably accounted for a larger number of side effects following a trans-psoas approaches, which either are due to manipulation of the genitofemoral or the lateral femoral cutaneous nerves, which can result in paresthesias and numbness over the groin as well as lateral aspect of the thigh, respectively. So obviously, due to these reasons, there is a significant need for intraoperative neuromonitoring in lateral access surgeries, especially the trans-psoas approaches. And there are different aspects of neuromonitoring are required in order to identify and prevent any new neurological deficit or worsening of a pre-existing deficit in a patient who is undergoing a lateral approach surgery. So there are several aspects of intraoperative neuromonitoring that we use. We'll touch upon them in brief. I'll go from below down. Obviously pedicle screw stimulation, especially when we are doing a lateral position surgery, is very, very useful. Transcranial motor evok potential as well as SSEPs are actually required in majority of these cases. It's ideal to have them as a standby, because some of the cases where it has been shown in some studies that the EMG, the nerve injuries that has not been picked up by EMG can actually be picked up on an MEP response, especially if it's a major nerve injury. So, but the most commonly used technique for monitoring in lateral access surgery is the EMG technique. And as we know, there are two main aspects of EMG. One is a spontaneous EMG, or what we call as a free run EMG, and the other is a triggered EMG, again, under which there are two different modes. So we'll discuss each of them a little bit in detail. So as we know, spontaneous EMG or a free run EMG is the recording of a spontaneous activity within the muscle, like spontaneous electromyographic activity within the muscles. And this provides an information on the state of the peripheral nerves that innervate the muscle as well. So these kind of activities, the spontaneous activity, can be in pathological conditions. Apart from the physiology, in pathological conditions, it can be due to compression of the nerves. It can be due to stretch of the nerves. It can be due to hypothermia or ischemia as well. And all these changes can result in a spontaneous EMG activity within the muscle. Now, the technique is the mechanism, that is underlying mechanism, is very, very simple. So EMG monitoring should ideally be quiescent under normal conditions. When there is a blunt mechanical nerve root irritation, it activates the motor nerve fibers, and this impulse is transmitted down the nerves and across the neuromuscular junction. This knowledge is important in order for anesthetic consideration, and because of this, it evokes a recordable motor unit potential in the monitored muscle. So ultimately, now there are several different types of responses that can be elicited based on different type of activity that we can see in the muscle. So whenever the nerve root manipulation is very minor, there can be only a short burst of motor unit potential. So as we can see in the upper figure there. So these are relatively innocuous, and unless they are repetitive, unless they are very frequently happening, we don't have to worry too much about that. What we need to be more careful about is the other type of responses, which usually represent a more blunt mechanical nerve root injury or prolonged retraction resulting in ischemic injury. And these basically are trains of high frequency motor unit potentials. So these are also called as neurotonic discharges. What is actually more ominous is a myochemic discharge, but usually they are seen only after a very severe nerve injury, and most often as a chronic response rather than an acute response. So again, what is more important to identify is the neurotonic discharges, which usually represent a major nerve root injury. Now, it is important for us to identify a particular nerve injury. It is important to actually record from that particular muscle. So there are several different muscles that are there, which are specific for that individual root value. So especially for L1, L2, we should monitor the iliacus, which is slightly difficult. And it's not required because, in the sense, most of this is actually a sensory pathology. L2-4 onwards, it becomes very, very important. Vastus medialis, L4-5 is TA or EHL, and S1-2 is medial gastro, and S3-5 is anal and urethral sphincters that need to be monitored. So when do we need to use free run EMG? The free run EMG, as we can understand, is specifically useful for during sequential dilatation. So because this is something that we are doing without any kind of monitoring, this is something that can result in changes within the psoas muscle, or it can cause significant pressure that can be transmitted to the lumbar plexus. So this sequential dilatation can detect any direct mechanical compression within the muscle or the femoral nerve getting pressed against the L5 transverse process. And especially while expanding the retractor, it can detect spontaneous EMG activities. And now comes the question whether this is also required in OLIF, especially in those Mickey Mouse psoas that we see in OLIF, where we actually retract the muscle significantly posteriorly, try to strip off the anterior portion of the psoas, the tendon and the anterior fibers of the psoas. And this is where, so far we have not done it, but this is where the question arises whether it is actually required in these kind of psoas, these kind of OLIF procedures as well. There are several theoretical limitations for us free run EMG. Of course, it is known that the spontaneous activity can be noted in one part of the muscle, which doesn't have an electrode in it. With that motor unit doesn't have an electrode in it, and whereas it may lead to some kind of a false negative phenomena. And it is important to distinguish any intraoperative recorded EMG activity from fasciculations and fibrillations, which can happen as a chronic part of a chronic denervation injury that is already pre-existing. And that is why it is very, very important to get a baseline EMG or a spontaneous EMG recording just before we start entering the psoas muscle. And this will help us differentiate whether this particular abnormal EMG recording was pre-existing or it has been induced during our passage of the probe. Coming to the next aspect is the triggered EMG. That triggered EMG, again, it's very, very simple. So we just stimulate a particular area. And if a nerve is close enough to that area that we are stimulating, the current gets transmitted and the nerve will get excited and it will result in a muscle contraction. So the principle is very, very close. That means this term is called as electrically close. Of course, it also means that there is a low resistance pathway that for the current to get transmitted. And there are different type of probes that are available, the XPAC probe or the ball probe, which we can use to stimulate and check at each stage of the surgery. So what is this current that we say is safe, or what is the current that is we say is not acceptable? So whenever a nerve or whenever we get an EMG response at less than 6 milliamperes, correct, it means to say that the nerve is very, very close. That means that it indicates that it is a red phenomena. So whenever it is between 6 to 8 milliamperes, when the nerve is getting excited between 6 to 8 milliamperes, it is a borderline zone, and it is recommended that we have to change our trajectory or change our entry point more anteriorly. Of course, whenever this nerve can get stimulated, if it is more than 8 milliamperes also, because ultimately the more current you pass, the more spread happens, and ultimately you can stimulate all the nerves within the psoas muscle. So whenever it is getting stimulated at more than 8 milliamperes, it is unacceptable. That means the nerve is significantly far away and we don't have to worry about it. So this can be done even with a XPAC probe, or there are stimulation dilators also that are available, which can stimulate in any one particular direction. Posteriorly, you can stimulate it across 3 to 4 quadrants on the posterior aspect of the operative field. So the second part is the nerve proximity mode, and this is almost similar, but this is like more of a continuous monitoring that happens. The continuous current is transmitted in order to find the nearest excitable nerve root. And that means that if the nerve response is again similar, response is obtained at a lower current, that means the nerve is very closer. So as you can see, the electrode now it is at the anterior border of the psoas, and the current that is required to stimulate the nearest nerve is nearly around 10. To elicit a nearest response is nearly around 10. Whereas if you move the electrode more posteriorly, it gets excited at around 5 milliamperes of current, which we know is not which we've heard previously that it is not a very safe zone. And somewhere around 7, again, this is again plus minus. So it is always better to have a green zone for as far as the nerve proximity mode is concerned. So triggered EMG has virtually significant applications. It can be used while passing the probe through the psoas, through the edge of the final dilator, before we put in the stabilizing pin, depth of the tube as we are, before retraction, or in order to before clearing the soft tissue, that is residual soft tissue over the disc and the upper and lower border of the adjacent vertebral borders. We can use our stimulation probe, ball probe, in order to stimulate that area to see if any nerves are there. So again, important thing is anesthetic considerations. I'll not be going into the details of it. It's important to preserve the neuromuscular function in order to get adequate responses. As long as this basic function is not preserved, all the monitoring aspects are not going to be adequate. Patient safety consideration should be always kept in mind for neuromonitoring. Tongue bite can happen in certain cases. There can be skin burns, especially patient movement also happens, because sometimes we have seen in the absence of skeletal muscle relaxation, the patient virtually jerks. An entire jerk is produced when we are stimulating an MEP or EAP. Coming to that, we have to understand the role of MEP SSCP. Whether EMG is an integral part, as I mentioned, it's almost mandatory for a trans-OS approaches. But nowadays we are using more and more of OLIF procedures where EMG becomes less and less important. There comes the importance of MEP and SCCP, which either due to distraction, either due to some other type of muscle pressure that is being transmitted due to the retraction of the psoas muscle. We can identify such changes in the nerve by MEP and SCCP. And in fact, there are several studies that showed that MEP defined the changes during XLIF even without EMG changes, and that is why it is very important. So to summarize, intraoperative neuromonitoring is an integral and important part of lateral access surgery, and EMG, as we have understood, is in its different modalities, is very, very important and a mandatory part of a trans-psoas approaches, not as much useful for an OLIF or an ALIF approaches. MEP and SCCP, we already know that it's better to have them as a standby in addition to the EMG responses. Of course, there are limitations. We know that the majority of the side effects used to be sensory in nature, and these nerves cannot be monitored. And that is why it is very important to understand the anatomy, identify the genitofemoral nerve before we pass our sequential dilators. Hip flexion weakness, as we understand, direct nerve injury can be prevented by utilizing monitoring. And in fact, the direct nerve injury, is actually responsible for a small amount of post-operative psoas weakness, whereas some of it can also happen due to splitting of fibers or an edematous reaction within the muscle. And these can happen despite adequate monitoring intraoperatively. Thank you.
Thank you, Umesh. That was an excellent presentation. So I would like to just ask you, where do you use neuromonitoring in OLIF? You just covered it, but I just want you to highlight it.
So we use MEP SCCP during OLIF. We do one baseline recording, of course, and then second recording is after retractor placement to see if any nerve compression has happened due to the retractor placement and after expanding the retractor. And then we do it after disc space distraction. Like once we distract the disc space, and then during the trial phase itself, before inserting the cage, we do an MEP SCCP, and if it is adequate, then we go ahead with the size that we have selected.
Ayush? Yeah.
So initial 1 year, we were doing neuromonitoring for OLIF. Last 1.5 years, we have not done any neuromonitoring. One of the things which I like is if you have muscle relaxant, it is very easy to retract your psoas. We find it better relaxation and better working. Only thing we do now is to make sure we don't compress the psoas. If it's a big psoas, then it could be a bit of problem. But practically, we have not seen any difference with or without neuromonitoring in OLIF. That is our experience.
Dr. Metkar, your experience?
Yes, so I do use neuromonitoring regularly, even for OLIF, but I usually use, it's not for ipsilateral monitoring. I use it for mainly to make sure that any disc prep or spacer placement or tire placement doesn't compromise the contralateral exiting nerve. So that's my main reason for using the neuromonitoring more so than any femoral nerve, because with the oblique approach, it's very unlikely that you end up damaging the femoral nerve or it's always there, and you can always check with the neuromonitoring, but it's mainly I use it for contralateral monitoring.
Guru, can I come in just 1 minute on that?
Yeah.
So I think there had been multiple studies. In fact, cadaver studies also has been done that when you retract psoas as a whole, when you are not penetrating the psoas, but you are retracting psoas as a whole, the stress on the nerve, the femoral nerve, is much lesser than when you are in intra psoas. So that is why generally, that obviates the need of using neuromonitoring in most of the cases. Even in those Mickey Mouse kind of psoas, if you retract psoas in toto, the chances of having compression is much less, or the stress on this nerve is much less.
Just one question to Umesh. I know that it's not possible, but still, any advances for monitoring the sympathetic nerves?
No, sir, not that I know.
It was just a question, because that's the very important part of this procedure.
That is something that we have not highlighted throughout this talk, throughout this session. Sympathetic nerve plexus usually lie right there in the OLIF window, that is on the lateral, on the anterior surface of the psoas, between the aorta and the anterior surface of the psoas. Sometimes, especially because I use a microscope in order to dissect, sometimes we can make out that there is a thin layer which we are not sure whether, but most of the times we feel that it's a sympathetic nerve. And especially if we are doing multi-level and if we trace this above and below, we can even see that ganglion in certain in some cases, and this can be visualized, I think, only under microscope. If you are doing it on a naked eye, I think again it is not visible at all. Most of the cases, sympathetic nerve injury is almost I'm not sure whether it can be preserved in any case if there is any technique, but most of the times I don't feel that it is under our control. The moment we enter the disc space in that OLIF window, the sympathetic trunk, the sympathetic chain gets disrupted at that particular level. Fortunately, unlike the Western population, the fair skin population, where the incidence of hyperemia and temperature changes in the left lower limb have been reported in a significant number of cases, we have not come across any major side effects due to the sympathetic chain injury.
One thing that I want everyone to monitor, because that's what we are monitoring for now 3 to 4 years also, is whenever you dock the retractor or whenever you manipulate the psoas and you are over the disc space, we are monitoring the blood pressure changes by the anesthetist. And we are finding that there are certain blood pressure changes which occur when you just dock in at the disc space, especially at L4, 5, L3, 4. So that's our finding. We are just going to monitor that further to come out with any staunch results for that.
Thank you, sir. I think given a choice, I think every one of us would like to monitor, but in Indian scenario, I think it's availability and the cost issues. But like Ayush pointed out, maybe the relaxation of psoas is also important. So what we usually would have do when we monitor, if we monitor, is initial, like when it comes to basically dock, we monitor, and then when we start retracting it, and then you can actually use some relaxation, and then again the relaxation way goes off in another 15-20 seconds, and then again you can start monitoring when you start basically distracting and all. So I think that was
Guru,
a very good discussion.
One more point. I initially faced a problem with the anterior few fibers of the psoas. Even with a retractor, they came in the way. So I was not very happy with the supra-inferior retractor during OLIF. So now I am not using that tubular retractor which the company supplied. Now I have a thin, long handheld retractors. I just asked my assistant to refract the psoas posteriorly. So it's a manual retractor now for me doing an OLIF, but that has made my life much, much easier. So even with a 3-level OLIF, I'm hardly seeing much of a thigh pain with a manual retractor compared to their tubular retractor. So that's much more comfortable for me now to use a handheld retractors rather than a tubular retractors.
Okay. Thank you, Dhruvin. I would like to invite Dr. Anand Naik, but Anand, I would like you to comment before you start your talk that is there any use of neuromonitoring in ALIFs?
There is no use of neural monitoring in ALIF.
So like Umesh mentioned that in OLIFs, they use it for distraction and deformity corrections when they do. But do you think like in ALIF, because we are putting a big, large cage, larger than OLIFs, so does it really matter to monitor in deformity cases at least?
No, it's not required.
Okay. Okay. So I would like to ask you to start your presentation. Dr. Anand Naik, he's our from Delhi, and he's our ALIF surgeon. So over to you, Anand.
Okay. Can you see the screen?
Yeah, Anand. Yes.
Okay. So good morning all. Today we'll be talking only about the minimal invasive ALIF approaches. So there are very different ways to do this ALIF. One is the anterior retroperitoneal approach. As you can see in the on the screen, the red colored line. The anterior transperitoneal approach is another technique in which you open the peritoneum and you directly go there. Direct and oblique lateral has been was a topic of discussion in earlier talks as well. There were others like percutaneous axial, but I think nobody is doing that. There are endoscopic, and then there are MIS circumferential considerations. So how the spine exposure for ALIF, is it the same as it looks in the picture? But I would say it's slightly different. It's not a typical, the GI approach or a vascular surgeon approach. And when you're doing this approach, either retroperitoneal or transperitoneal approaches, you're it's assisting on the spine, but also at the same time, you're protecting and monitoring all your vessels throughout the surgery. It's not a very difficult approach or a time consuming, just you need to have a little few assistants in the cases, and then you can assist your GI surgeon as well. And it's very easy, it's very simple. It hardly takes 5 to 7 minutes to reach there, to finish off the entire approach. So this is a small video.
Exposure, we prefer a transverse incision whilst marking the midline to get better positioning for
this
the
was
linear
published in
elbow.
JSS
Dissection through the skin and
by
soft tissues is
Mobs,
performed
Matthew Scott
using
Young and myself.
diathermy, and a superior and inferior flap is raised to give us our vertical exposure. The linear elbow is divided with diathermy.
So the linea alba is taken out. You can see the fat over the peritoneum over there. And then once you clear that, you can use your fingers to do the dissection, or maybe you can use a sponge on a stick or a peanut like this, and you clear out the posterior rectus sheath. And there you can see the retroperitoneal, and you move it across and you see the psoas muscle over there.
Vein is exposed, the median sacral vessel is double clipped and divided, and blunt.
After the clipping of the sacral anterior, this is for L5S1. After clipping this vessel, you can see the vessels over there, the IVCs forming over there, and the aorta. You can incise the anterior part of the anterior annulus, cut the ALL, take out all the disc material, whatever is available, and you can prepare. Yeah, use your carisons, pituitaries. What I do is put a small distractor, lift it up, and then clear out all the disc materials. Go all the way up to the back, prepare your end plates, take out, curate out everything from the back, remove everything, go in, check the
position as per.
And then after trialing preparation of end plate, and then you can insert your cage there. So this comes with a zig. So one screw goes down, one screw goes up, and then you put the locking nut after the implant fixation. And once this step is done, you take out all your retractor blades, the vascular blades and the peritoneal retractor blades, and you will see that everything is going back to its, everything will move back to its position. Yeah. So the last one goes out, and everything is back to its position. And then you can suture the linea alba with a non-resorbable sutures, the continuous locking or non-locking technique. And then you do the subsequent subcutaneous things and all. So why do we need ALIF? ALIF is one of the ideal methods of stopping a movement at that particular segment. It allows complete removal of the pain generator. You can take out the entire posterior annulus by this approach. It increases the disc height and also the sagittal and coronal balance, and probably one of the best methods to achieve coronal and sagittal balance when compared to any other approach. It is a static stabilization procedure, and therefore the graft is always under compression. The graft is always under compression, and you achieve a better fusion rates with this. But there are some complications associated with this kind of approach. One of the most common, which we are all worried about, is pseudoarthrosis. But with the advent of ALIF and all the biologics and technologies coming on, now we have 100% fusion rate within first 6 months, 3 to 6 months. Subsidence, if you damage end plates, it's going to subside. So if you're over distracting the disc space, it is going to subside. So you need to always calculate how much tension is there when you are putting in your cages. See whether the facet joints are opening up or not while doing the indirect decompression. The third most common complication, vascular complications, which most of us are worried of, are aerotic and IVC injuries. So as you have seen in the video that you can see the vessels over there, you are monitoring that, you are seeing the pulse, and you can put a saturation probe on the toe of the patient. Um, and you can, if there is any IVC injury or anything, you just have to clip ligate or then, or maybe a repair with 30 or 40 proline. Aerotic injuries, you need to have those clamps to control the bleeding and isolate the artery, and then you can repair that. Aortic injuries are much easier to repair as compared to the IVC. Trust me, I had both of them, and we were able to repair that. Post-operative ileus is very common in these kind of approaches. By the retroperitoneal approach, it's slightly less in retroperitoneal, but transperitoneal, almost every patient will get that bloating. We have pseudo obstructions. We can see that. It's very difficult to predict who is going to have the pseudo obstructions in the post-operative period, but the fluid balance, it plays a very important role to achieve, to do that. The much talked about was retrograde ejaculations. We have done a small study in around 7,800 patients starting from 2004 to 2017 in young reproductive male groups, in which we did all the pre-operative urine analysis for any occult retrograde ejaculations, and then the post-operative analysis was done. And the incidence of retrograde ejaculation in a young reproductive male group undergoing an ALIF procedure for L34 or L45 and L5S1 was less than 0.84% in our series. Ureter injuries, when you move the peritoneum to one side, ureter is the first cord-like structure which you can feel. And most of this approach are blind, either it's done with the fingers and all. You need to feel the ureter and move it along with the peritoneum. And when you do that, one layer of the sympathetic plexus goes with it. The other layer stays over the formation of IVC or near the bifurcation of aorta, which is the sympathetic plexus. And you need to be very careful. You cannot use a bipolar, or if you're using a bipolar, you use an isocool one. Otherwise, don't use it, or maybe a gentle finger dissection. Um, Lymphocyl, I still have to see this complication, but it's mentioned in the literature. So what are the benefits of ALIF or MIS ALIF? For the patient, it's one operation most of the times. It has minimal blood loss. The complication rates are very less. There is quick functional recovery, very high fusion rates, and very faster fusion rates in ALIF. The adjacent segment degeneration rates are very minimal. And for the surgeons, it treats the discogenic back pain. It allows proper restoration of the sagittal or coronal balance, be it L5S1. It's already proven, it's there in the papers, but also at L4, 5, L3, 4. It's less OR time and anesthesia. Usually L5S1 takes around 35 to 45 minutes, but that's an average time. It can be more, it can be less. Blood loss is usually less. Hardly see around 30 to 40 ml blood loss in 3 level, L3, 4, L4, 5, and L5S1. And rarely a person needs any blood transfusion unless I damage something. It's an easier and more enjoyable surgeries as a surgeon. So thank you.
Thank you, Dr. Anand. Are there any questions for Dr. Anand from any panelists? So if not,
Guru, can you ask what are the salvage options? Because sometimes you have a cage protrusions or screws back out, and what are the? It's a very good approach, definitely, but the main problem comes of not during the approach also, but post-operatively when there is some thing which is going wrong, and there is a salvage which is required.
Sir, if the disc space is prepared properly, and if you take out the end plates and all, and if your cage is as posterior as you can, if you can reach there, and if you can lock your screws properly, then very rarely it will come out. Most of the disc this cage subsidence in ALF is because of improper disc preparation. Either the disc material was not removed completely, either the end plates were not taken out completely. The anterior cage subsidence is very dangerous in ALF because of blood vessels over there, and even if it is around 5 millimeter or 8 millimeter anterior protrusion, then over a period of time there will be pseudoaneurysm or maybe some kind of pressure kind of damages to the IVC. And so what I do is I put my cage in after proper disc preparation and put an anti-adhesion barrier over there, which is a cardiac patch, so that even if there is a subsidence, there is a layer. And even if I have to do revise some other level, the vessels are not adhered to the prevertebral fascia at all.
Now, Anand, what Dr. Jala wants to know is what are the salvage options, if at all, if it happens? We take it as it's rare thing, but if at all it happens, what options do we have?
So either you go from the front again, yes, approaching the abdomen again is always a challenging and always a difficult task. But if you have used the right-sided approach, you can go through the left side. If you have done the left-sided approach, you can go through the right side. You can change the switch over. Or maybe if you are still very adamant to go through the same approach, you extend the ureter so that you don't damage ureter when you are retracting that. Go in, take out the cage, whichever has subsided or backed out. Prepare the end plates again, see if the end plates are damaged, if there is any subsidence. It's like a partial corpectomy over there, and put a bigger size cage, put a plate over there, and then you may have to fix posteriorly as well.
So have you any time?
Thanks, Anand.
Yeah, yes, sir. Dr. Jala, do you have any comments, sir?
That's okay. That's okay.
Okay.
You can also go transperitoneal. That's another option.
Yeah, so transperitoneal is a good option, but we see a lot of post-operative ileus, and a lot of people, they are not happy with post-operative ileus. It continues maybe up to 4 days or maybe up to 7 days. The patient is kept NPO and all. So transperitoneal is slightly bit, I would not prefer. It's a doable, but I would
salvage, as a salvage, not as a primary.
Yes, sir. But I am worried about in transperitoneal, the retrograde ejaculations. The rates are very high in transperitoneal because you are taking out the sympathetic plexus from the layer of peritoneum, whereas in the retroperitoneum, you are moving the entire layer across.
Okay, thank you.
Thank you, Dr. Anand. As usual, it was an excellent presentation. So now I would like to invite our guest speaker, Dr. Umesh Metkar. He is one of our own who has made big in US now. So he is a professor at Harvard Medical School, Boston. And,
let me interrupt. I'm not professor yet. I'm just an instructor. Professor is a long way away.
Okay. So he's going to talk on basically OLIF, basic anterior approach. And Dr. Umesh Metkar, over to you.
First of all, I would like to thank everyone for the opportunity. It's always fun to interact with everyone from India and talk about these different types of surgeries. And OLIF is one of my favorite surgeries that I do these days. I've been doing this for almost 5 years, and I always love to teach this to the residents and my fellows and even the visiting fellows. So let's start with. So let me give you a few common scenarios that I use OLIF for. So this is a 60-year-old lady who has a severe foraminal stenosis, grade 1 to 2 spondylolisthesis, L4 radicular symptoms, and the MRI showed significant stenosis in the foramen and severe lateral stenosis as well. Then another case scenario which I come across commonly. Now this is a 73-year-old gentleman. He had severe spinal stenosis from L1 to L3 and had a large disc herniation. So I did a discectomy and 2-level laminectomy for him. And then after a year of surgery, he started developing anterolisthesis at one level, retrolisthesis at the other level, and developed severe foraminal stenosis. So when I thought about this patient, now I need to fuse him for sure. And if I just do posterior approach, there won't be any bony scaffold left for fusion mass to grow across. So I had to do something different and do something anteriorly. So this was another time that I started thinking about OLIF. And then the third type of patients that I commonly see is a deformity, adult degenerative deformity patient. So this is a 63-year-old gentleman, very active gentleman with progressive coronal imbalance, loss of height, right side L3 and L4 radiculopathy caused by the deformity. And then this is another clinical scenario where I started thinking about doing OLIF. Now, what are the advantages of OLIF? So there are certain patient benefits, there are certain procedural benefits there, and then it's better for surgeon, and economically it's somehow better too. So main patient benefit is this approach is completely anterior to the psoas. So if you think about OLIF is, I mean, we've been doing surgeries anterior to the psoas for a long time. It's just that the OLIF has been popularized lately, but most of our anterior surgeries back in the days used to be anterior to the psoas. We used to retract the psoas and do the corpectomies and do the anterior surgery. So this is just a modified anterior approach, and it allows us to directly visualize the disc space and the vertebral bodies. Then there's an advantage with the patient positioning. There is no jackknifing required, which you need for the DLE for the lateral lumbar interbody fusion. And then with the retraction of the psoas completely, there is less of a risk of nerve injury. The procedural benefits are, there's a good sagittal realignment after the spacer placement. There's a possibility of using indirect decompression. Then there is also a significant coronal plane correction. So I have found this very useful in deformity patients. And then the main advantage, what I always think about when I compare about ALIF, OLIF, and lateral transverse approaches, the reason I like OLIF the best, it gives you a better understanding of 3D orientation of the vertebrae. This is important in patients who have deformity. So in OLIF, you can see the lateral aspect of the vertebra almost up to, so if you look at it as a clock, you can go up to almost 3 o'clock, and then up to the 7 o'clock, you can see the whole, that corridor, and that gives you an orientation of the vertebra in a orthogonal view. Also, you can place easily place a spacer in L4-5 even if the iliac crest is in your way, and you can use the same approach and go between the bifurcation, or sometimes lateral to the common iliac vein and put a space in L5-S1. For a surgeon, you can avoid giving paralytics, makes the surgery easier. Ergonomically, it's better for the surgeon because you're upright for the whole procedure, as compared to DLA for lateral lumbar interbody transverse fusion, where you have to bend over and go keep your neck bent over all through the procedure. And then the biggest benefit is what I always like about this is for a Scoli patient, when I do these surgeries, I do L2 to S1 in one single sitting. I don't have to divide it between XLIF and an ALIF. And then neuromonitoring is obviously optional. It could be an economic benefit for the patient. Now, this is where this was first studied by Rasoli and his colleagues, that they established the safety of OLIF procedure, where they did OLIF procedures between L2 to L5 with a mini open approach on 179 patients. And they demonstrated this has been a safe procedure and there was no need for neuromonitoring. And there was a group, this was a study published in Neurosurgery Spine in 2015, which studied actual T2 images of MRI and studied the corridor available for the OLIF procedures. So when you look at the OLIF corridor, this is what we are talking about. We are talking about the space between the greater vessels. Either it could be the left common iliac vein, or it could be aorta, or it can be right and left common iliac arteries and the psoas muscle. So to measure that the dimension is is very important, and that this is what the planning is important for. So they studied this corridor, and they found that at L2, 3, and L3 for levels, OLIF could be performed in almost 100% of patients. Adequate corridor could be found in 100% of patients. At L4-5, almost 91% of patients had the adequate corridor. And for L5-S1, they measured the distance between the midline and the left common iliac vein. And the OLIF, it was adequate for almost 69% of patients. This was one of the largest OLIF studies where they performed OLIF in 812 patients and used the axis and found that the risk of vascular or neurologic injuries very low, and then its neuromonitoring is not necessarily required. Another study where they, in 2016, they studied 155 patients and then looked at the perioperative and postoperative complications with OLIF surgery. So they found that the main complication was subsidence of the spacer, was found in 18.3% of patients. There was transient psoas or thigh numbness in 13% of patients, and only 1.9% of patients had direct injury. Now, my own experience, I've done more than 80 of these cases in simple to complex, even for complex deformity, regardless of whether the convexity is on the left side or the concavity is on the left side. I'm able to do OLIF in all 4 levels, more than 150 levels. There hasn't been a single patient with femoral nerve injury or obturator nerve palsy. 2 patients had transient psoas weakness that lasted for a few days and got better. 1 patient had a minor vascular injury. And just recently, I was doing an L5S1 OLIF and I had a major vascular injury. And fortunately, I have a vascular surgeon that does the exposures for me. Medical legally safer. He was able to repair it, but that was probably the maximum blood loss I've ever seen in a patient. And then 1 patient had a transient retrograde ejaculation, which got better after a few months. So what are the rationale behind the technique? The biggest drawbacks of lateral transverse surgery are kind of the advantages for OLIF technique. So if you look at the L4-5 disc space and think about when you start planning for a lateral surgery, majority of the patients have the iliac crest that overlaps their or superimposes on their at L4-5 disc space. So if you see at this, look at this X-ray and look at how the crest is superimposed on L4-5. In this patient, you cannot do an lateral transverse surgery. So having the oblique corridor kind of negates the need for going transverse or having direct approach. And then another advantage for this OLIF technique is using that articulating inserter, where even if you don't have a perfect trajectory to the disc space or a perfect anterolateral annulotomy, you can still put a orthogonal spacer using the articulating inserter. So for this patient, if you look at it, the disc space is completely covered by the iliac crest. You cannot do an lateral transverse surgery for this patient. At the most, you can think about doing an ALIF for this patient. Now, this was easily done with an OLIF technique, and good spacer placement and screw placement could be easily achieved. Now, if you compare it to the different approaches, it's a truly muscle sparing approach as compared to when you look at the PLIF, you have to dissect through the muscles. If you do TLF, it's also a transmuscular approach. Transverse is transmuscular approach. OLIF has the truly intermuscular approach where you're splitting the muscles all through the approach without dissecting or cutting them. And this is the major benefit also for L4-5 level is that there's a very low risk of femoral nerve injury. So in this is a cadaveric lab where the needle was inserted under CM guidance at the midline of the L4-5 disc space, and then the dissection was carried out. If you see here, the needle actually traversed through the femoral nerve into the disc space. So the risk of injury for an ideal spacer placement at L4-5 is very high, and oblique approach allows us to prevent that injury. Other thing to consider, if you look at these neurograms and the retractor placement that's done for the lateral transverse approach, majority of times you may end up escaping the nerve root the femoral nerve injury because of the probing that you do during the transverse approach, but the retraction of the posterior blade and then compression of the nerve against the L5 transverse process is what usually would lead to a femoral nerve injury, and that may not be detectable by the EMGs, but I think that's why that transcranial motor evoke potentials are important in these patients. Now, if you compare the OLIF to the ALIF and lateral transverse interbody fusions, so ALIF allows you to access L5S1 easily, and the access becomes very limited as you go higher into the spinal column. So L4-5 and L5S1 could be easily done. For L3-4, it could be really challenging, and you need a really good vascular surgeon to perform that. It does need a lot of mobilization of great vessels, and there is a need for extensive retroperitoneal dissection. For the transverse approach, it can be easily done at L1-2, L2-3, and L3-4. For L4-5, in majority of the patients, it could be challenging, and L5-S1 you cannot access through the lateral transverse. And the risk of femoral nerve injury is higher, risk of postoperative hip flexion weakness is higher. A lot of patients complain of that, and you can't access the 5-1. While when you do OLIF, you can do all of these levels in a single position, single surgery without any difficulty. Now, and also technically, it's better for the surgeon if you look at the overall, if you do the lateral transverse surgery over a period of a long time, it's physiologically and ergonomically not good for the surgeons. Now, what are the differences, technical differences between standard transverse technique and oblique approach? So mainly, you start from the planning perspective. When you look at when you plan for the transverse approach, you think about how the exercise look. If there's a superimposed, is there superimposed iliac crest on the 4-5 disc? Is there a low riding T12 rib? Those things come to your mind. But when you start planning for oblique, you mainly start looking at actual T2 MRI sequences and start planning and start looking at the vessels. Also, the big difference is in the patient positioning. So OLIF is always left side first, left side up, and because of the aorta, it's easy to retract the aorta and the arteries, and the risk of vascular injury is lower. So left side is always up. You don't need to jackknife the patient. You don't need to bend the bed for the patient. Incision is for transverse surgery. You have to make the incision right over the disc space, where you have to put the spacer. In OLIF, the incision is 5 to 10 centimeters anterior to the mid-axillary line. Neuromonitoring may or may not necessary. And then fusion preparation and trial and implant insertion is done with an orthogonal maneuver as compared to directly orthogonal approach for the transverse. So if you look at the pre-operative planning perspective for these patients, so this is a patient with, you can see a lytic spondylolisthesis grade 1 to 2. You can see that the disc space is completely covered by the iliac crest. There's a low 12th rib. So these are kind of contraindications to consider transverse surgery. Also, you have to look at which side is easier to come from. Is it easy to come from the right side or left side? But if you look at the OLIF patients, you start looking at where the aorta is, where vena cava is, and what's the dimension of the corridor, and that's how you start planning for the surgery. And once you start doing this, you automatically start thinking in terms of where the vessels are. It's also important to check for the transitional segments or where the aortic bifurcation is. Look for any irregular vasculature or pelvic kidney. I had a patient who had a pelvic kidney, and I was thinking of doing an anti-surgery, and I was surprised. I had never seen that kind of anatomy before, and I saw the kidney right in front of the sacrum. So those kind of patients are contraindications. Another thing to look for is if you look at these vascular anatomy for the left common iliac vein, if it's completely plastered to the bone, those are not the safe patients to do the L5S1 OLIF. those patients are better served with doing an anterior lumbar standard ALIF technique. If you see that the common iliac-when for an alpha H1 is kind of oval in shape and there is no fat between the vessel and the vertebra, those are kind of non-retractable vessels. The risk of vascular injury goes up if that's the vascular anatomy for the patient. Transitional anatomy also needs to be carefully looked at, and it's important to look at where the vessels are, where the bifurcation is, where would be the iliolumbar vein. And sometimes I have the vascular surgeon look at these things as well with me before we plan for the surgery. And I don't know who does this blindly, but I think direct visualization is recommended for all these procedures, regardless of how good you've become or how many you've done. So this is what I was talking about. If you look at this vein, left common iliac vein, if there's no fat between the vein and the vertebral body, and if it's an oval in shape or sometimes even flatter, that means that vessel is already stretched at that disc level. It will be really difficult to retract it either side to get the spacer in safely. I have a very good vascular surgeon. I mean, one time I had almost similar anatomy. The vessel was kind of round in shape, so I was able to go through between the common iliac artery and the common iliac vein and put the spacer. But with my recent experience of vascular injury, I'm going to be more timid from now onwards. Now, what are the major differences in the OR setting? So if you look at the transverse approach, it can be done either on the right or left side up, but you have to jackknife the patient. You have to bend the bed significantly. The break is not required for the OLIF patient's left side is always up. And the biggest thing is you can leave the legs extended, and you do have to adequately pad them. For a transverse surgery, you can either stand on the anterior or posterior side of the patient. But in OLIF, the surgeon always stands on the anterior side of the patient and CM comes from the opposite side. So this is how the standard setup looks like for OLIF for me. So I usually keep the new monitoring person in the far corner with their monitor, and then CM comes from the back of the patient. Surgeon and my assistant stands here, the scrub take. CM monitor stands here, Bowie bipolar, and then anesthesia at the top. It's important when you start doing surgeries to put this picture in the preference cards in the operating room so that they get it set up from the beginning itself. So always left side up, adequately pad the patient's limbs to make sure that the common pyramid nerves are well padded. I usually flex the right knee and then extend the left hip and left knee completely, so that it's important for transverse surgery. We flex the knees to relax the psoas so that we can retract it easily. For a OLIF approach, we want it to be fully taut. That's why we extend the hip so that the diameter is at the smallest possible. Diameter is the smallest possible so that you can retract it and you get the better corridor. Put the axillary rows, put multiple pillows, use a good amount of tape to secure the patient. And then it's important to get a true AP and a lateral view. So when you put the patient on the table, once everything is done, I start with an AP view, make sure that I get a true AP where I can see the pedicles nicely and the spinous process exactly in the midline between the pedicles. And then when I do, after that, once I do that, I get a lateral view to make sure that I get a nicely orthogonal end plate. Always work perpendicular to the floor, similar to the transverse surgery. Always move the patient at the bed and not the C-arm. And then for multi-level cases, you may end up adjusting the bed frequently. Now, this becomes really tricky in patients who have deformity. I mean, severe deformity, severe lateral listhesis. Getting a perfect AP or a perfect lateral may not be possible. So what I always focus on is I make sure that I am able to see the posterior wall of the vertebra orthogonally. I don't want any rotation that way. Once I know that for sure, then I do everything based on my cross-table AP views. So once I know that where my posterior border of the disc is and my canal is, I do everything, the spacer placement and everything under AP views. Standard draping, towels, sticky drapes. It's always important to drape and keep more area open. In case of a vascular injury, you may have to open more than what you planned for. So always drape a wider surface of the body, and hopefully you won't need it, but it's always good to be ready for the worst. Then next step is obviously mark the disc spaces, mark the angle of the disc, mark where the midline is, and and then accordingly you take the incision. So higher up, you tend to be as close to the midline of the disc as possible, and then as you go further down, you tend to migrate away from the mid-axillary or midpoint of the disc space, so up to 10 centimeters. And at 4.5, sometimes at 4.5 and at 5.1, you have to be significant anteriorly. And it's important to draw all these things and always try to put the retractor in a way that you are in an oblique trajectory. At the higher levels, you can almost you can keep it almost to orthogonal position or perpendicular position. For a single level, make an incision. You can make a small incision at the disc level or along the disc, and at multi-level, you can take incision between two discs. Now, once you do the initial incision, subcutaneous dissection, and then obviously, as we were discussed in previous talk, you come across the muscles of the abdomen wall, the external oblique, internal oblique, transversalis, and then the transversalis fascia. Once you go through that fascia, try to go along the posterior wall of the abdomen, and you come across the quadratus lumborum, and then you feel the TP and the psoas. And once you come further anteriorly, when you feel that, you feel the vascular pulsations, and you know that, and then you feel the disc space also, and that's what tells you where you are. And all this dissection, blunt finger dissection using a sponge stake or Kidner is really useful. Once you feel the psoas, you already know where you are. It's always useful to use a lighted retractor to create the space and retract everything anteriorly. It's important to look at the ureter, how it's traveling, and make sure that it falls up with the abdominal contents. Now, once you do that, then I always do it under visualization, set the initial dilator, get an X-ray, and see where I am on the disc space. My goal has always been to insert my initial dilator at the. So if you look at the lateral view, I divide the disc space into, say, 100 yards or 10 different segments. My goal is always to insert the initial dilator at 20-yard line, and then I start my annulotomy behind that. So you can see the difference in the docking of the retractors and the tubular system in transverse versus OLIF technique. Now, once you insert the retractor over the dilators, it's important to align the retractors in line of the disc space so that every step of disc prep and implant insertion can be easily done and without damaging the psoas or the nerve structures. So now, once you have the retractor, I start the annulotomy at around 20-yard line. And this is when you do the annulotomy, that's that part, and then implant and trial placement. Those are the only 3 steps of this procedure where you really need to retract the psoas. For rest of the procedure, you can do the whole disc prep using hockey stick instruments and don't have to retract the psoas. So that's the major benefit over a lateral transverse approach, where in the transverse approach, you have to constantly, for the whole disc prep implant preparation, you have to keep the retractor retracting the psoas, while in OLIF, the retractor retracts along the line of the psoas and doesn't put any pressure on the psoas and the femoral nerve. So that has been the biggest, that's the biggest advantage of OLIF technique. And then you can always elevate the psoas. You can use the nerve root retractor that we use posteriorly. You can use that and undercut the annulus underneath the psoas. And then once you do this or do these steps, then all the disc prep can be done with an orthogonal maneuver. So you always enter obliquely, and then as you go across almost up to 50% of the way in the disc space, anteroposteriorly, then you start doing things orthogonally and start going to the contralateral annulus. Can be really tricky for L4-5 space if the iliac crest is superimposed. So all those patients, you have to use a hockey stick instruments and do the same thing and use a articulating inserter. So you can see how you start at around 20-yard line or 20-30% of the way. And as you start going up to midpoint of the disc space, then you start doing the orthogonal maneuver and start bringing your hand up. And then you do the contralateral annular release using the Cobb retractor. Then the trialing is simple as the transfer surgery, but it's important to understand how it's lined up. You make sure that in AP and lateral you see the certain grooves that the spacers have. It's this articulating inserter is one of the biggest advantage I feel that OLIF has, because you can, in majority of a lot of patients I've had where I was barely able to do annulotomy between 4 and 5 or 4 to 6 o'clock position, or even 5 to 6 o'clock position. But with the help of articulating spacer, I was still able to put orthogonal spacer. So you can see how that can be used to slowly maneuver the spacer in the perfect lateral position. So this is the first patient I had shown where the patient had a scoliosis, and I was able to put these multiple OLIF spacers using OLIF technique. Thank you.
Can I ask a question?
Yeah.
So this is to everybody who's doing OLIFs here. What are the initial problems, initial complications or initial part of the learning curve, things that one can anticipate and learn from you guys? Is it could be with regards to the, docking, with regards to the orthogonal maneuver, the feel of the posterior annulus that will prevent you from going more posterior, things to do with the pins.
Yeah, so I think the initial difficulties were to first and foremost to do the surgery by standing on the anterior aspect of the patient was a little difficult, and then it's always tricky to keep constantly looking at the C-arm views and make sure that your spacer is turning the way you want to, and it's not going into the foramen. So the spacer has certain radiographic markers in a peak spacer, so they tell you how the spacer is moving. So it took few cases to really understand, for me to understand, okay, if I do all these things, then spacer would not necessarily go into the contralateral foramen, or I won't go into the spinal canal. And then also where I do my annulotomy, initially I used to push really hard to get my annulotomy as far posterior as possible. But as I've done more and more of these and started using the articulating spacer and the orthogonal maneuver efficiently, nowadays I don't even worry where my annulotomy is, even through as long as it is big enough to put the spacer in. I don't really worry about where it is positioned. Even if it's between 5 o'clock to 6 o'clock, 4 to 6, I can still put a spacer orthogonally.
And is it easier with the microscope or without a microscope, doing the entire surgery?
It's either, I've never used a microscope for this. I feel that it's easier. It gives a broader field of vision, and if with a tunnel vision of a microscope, it can sometimes become difficult. The reason I say this is for deformity patients, it's important to get the 3D orientation of the vertebra, because you cannot have a perfect AP or a perfect lateral view for every single level. So if you see the lateral and the anterior aspect of the vertebra you have a gross view of it, then you can get a 3D orientation of vertebra, and then just based on that you can do the whole surgery spacer placement without any difficulty.
Can I answer that?
Go ahead. Yes.
So, well, see, ultimately the vision is just tubular. So whether we are seeing that with a naked eye or with a microscope, the tube size is not going to change. We are not reducing the tube size or the retractor size just because we are using a microscope. So microscopes helps us to identify structures, especially during the initial part of the dissection. I completely agree that during disc space preparation, once you have got your access, once you have put your stabilizing pin, probably passing those large instruments, cobs and all those things are much better without the microscope. But at least until we dock that initial retractor, I've done without the microscope, I have done with the microscope, but I feel that with microscope you are much more confident of visualizing even those small blood vessels that otherwise may lead to some kind of a bleeding and unnecessary traction, which may be which may be joining a bigger vein or a bigger vessel. That kind of an injury that we can probably prevent. And we can easily identify, especially nowadays, at least for all cases that we have done at L3, 4, 4, 5, we are able to see the genitofemoral nerve clearly. And we are able to retract that. And then usually, again, we keep that retractor, the nerve root retractor in place on the genitofemoral nerve and pass the dilator. Because ultimately, even though the genitofemoral nerve is on the surface, when we pass bigger size dilators, the bigger size dilator may actually cause some amount of compression on the genitofemoral nerve. And this we have observed also. So I feel that until we dock the retractor, a microscope usually makes a lot of difference.
Arvind, I just would want to narrate my experience because, in my first case, I remember that was, I encountered three complications in one case. That was my first case. First thing was, psoas was, when I docked my retractor, psoas was somehow, I was not, it was not a Mickey Mouse kind of a psoas, but still it was not an ideal case. So psoas fibers were coming. So I learned that, initially when you are doing, probably soft docking is something which you always perform before, you start fixing your pin, that, soft docking helps you to swipe psoas away. So hard docking should be the second stage. The next thing which I encountered was, I was a little careless in putting the pins. And unfortunately, in that same patient, my pin directly went into the segmental vein at the 3-4. And my patient has a small, not very elaborate, but a post-operative retroperitoneal hematoma. And third thing, it was a very rigid osteophyte. So I tried to use a shaver of 8 size and, without much trying to release opposite side, and I just rotated the shaver and shaver got broke inside the disc space. And I had, I was sweating to remove that broken. So, this 3 complication in just first case, actually, I had no beginner's luck in that case, but I learned a lot from that case that, so initially you have to release opposite side properly before you start putting your larger size shavers or sizers or whatever. So this release is very, very important when you are doing OLIF, specifically in a collapsed disc.
Arvind, what I would share my experience of what was my first case. My first degenerative case was in August 2016. But from May to August, I did my all infective cases where I never wanted any decompression or anything. And we all know how the anterior approach works. So I was just doing all infective cases where there was only back pain, you required like postoperative discitis or maybe tuberculosis, where you don't require all these fancy things to be done. So you are very well versed with your approach first and your approach to the disc. And then I started with degenerative. So that's what I started. So I did not have a much issue of docking or anything when I did my first degenerative case. But in the second degenerative case that I did, again, that was in August the same, but that was my second case of degenerative. I got a contralateral radiculopathy and the patient was in severe pain. And the biggest problem is not doing a good orthogonal maneuver. And my point of docking was slightly middle to posterior rather than anterior to the middle. So I think the best way to do is start with an infection. We have a lot of infections here, and you do that first.
My first case was ilolumbar damage. There was a lot of bleeding. Had to cut open, identify ligate, managed. Second case, I got 3 ilolumbars again, and that was bad luck. But this time I was prepared. I was able to, dissect and clip ligate. The incision was slightly bigger. Then I was afraid. It was in 2010, my first case. But now I'm a bit confident with ilolumbars, even if they are there at L4-5 in OLIF. But I rarely do an OLIF for L4-5. For me, up to L3-4, I'm good with ALIF. For me, OLIF is only for L1-2 or L2-3 only.
Actually, Anand, I would say that it is better to do LLIF at L1-2 and L2-3 rather than OLIF.
Yeah, I see at L1-2 and L2-3, it's significantly no difference.
In between,
it's only that coastal margins and all, it's there in that way. Yeah.
Gives a loop and a headlight for my OLIF approaches. So, I mean, I can identify sympathetic chain almost every time. So that helps.
Yeah.
Loop and a headlight.
Actually, sorry, I was out. My net was down. So I was just hearing, and my first case was very bad degenerative scoli. I think, like Neeraj said, I had a beginner's luck. I didn't have many complications, but I had to open it more than what I do now. So I actually opened it like a mini open, and then I saw all the structures and then docked my retractors. But other than that, there were big osteophytes and all. Then I had to take down. So I think it's different for each and every case when we do these. I think Dr. Jala was at our center and he did one 4-level OLIF, and it was again a different challenge. So I think anybody else has any questions? Ayush, you were raising.
Yeah. So for me also, we started with a general surgeon initially, with a much wider incision to start with, so that we can be, although we started with the tubular system, but we sort of did a mini open complete approach and then put the tubular system in, just to get used to the anatomy initially. The debate between when it comes to the debate between the microscope and open eye, I do believe magnification and the light source is very, very important. The problem with microscope is when you're taking that lateral shoot, you every time you have to take your microscope out. So the compromise is, if you use a good loop with a light source, I think you can manage both. The good part about loop is you can have your CM always in the lateral position, and you don't have to do, because you go through oblique corridor. So there's no shadow. But if you're using a microscope, the caveat to using a microscope is that every time your CM comes in, your microscope goes out, and you do lose some time. So that is what our thought process.
I have a question for Amit Bhai. For everybody, in open tail lifts, we are used to seeing a very fluid bone-to-bone fusion when we do open tail lift after, say, 2 years, 3 years, 4 years. I have yet to see a very fluid bony fusion in OLIF cases in a post-operative X-rays or a CT scan. I mean, I don't know. Any experience?
So I have done a study, initial study that we did 40 cases where 20 were with the allografts, or I would not say allograft, but the bone graft extenders, and the 20 cases were with the initial cases where we are not using this hydroxypeptide, we were just using the iliac-based bone graft. And we did 1 year CT scan follow-up. And I'm following these patients as on today also. So at 1 year, if you do these CT scans, according to the Steffi and Brenningen criteria that we use for CT scan and the X-rays, we got around 91 to 92% fusion of grade 4 or 5 fusion criteria. But if I follow up it for more than 2 years, then I'm definitely seeing a very good fusion. Like as you see, still if also your fusion starts, maybe at 1 year, you are not very confident whether it's fused or not. But if you see more and more after 2 years, you definitely see a very good fusion and even the cage which has been incorporated. So that's the longer the follow-up you get, you will get to see these things more.
Okay. Anand, I think we'll have to wind up because of the time constraints, because Umesh also needs to update us about the MISSAB surgery course. So I would like to thank especially Dr. Umesh Metkar for taking out time, and it is very late in Saturday night there in US. And when I asked him, he actually willingly agreed, and he is always there. He actually gave some few talks with ISIC team. So I would like to thank especially Dr. Umesh Metkar for sparing his precious time here. And I would like to thank Dr. Umesh Srikanta, Dr. Ayush, Dr. Dhruvin Patel, Dr. Anand Nayak, Dr. Neeraj Vasavda, and our President-elect Vice President, Dr. Amit Jala sir, for his basically experience, sharing his experience with us, and Dr. Arvind Kulkarni for giving this opportunity to conduct this wonderful seminar here, and Dr. Neeraj Bijlani for hosting us, and Dr. Abhinandan also. I would like to ask Dr. Arvind Kulkarni to take over from here. Dr. Arvind.
Thank you, Guru. This was one of the best webinars that we've had in the last 10 months. Superb. And I think we can, this is a very great faculty. If we could have had a, cadaveric session just after these lectures, it would have been, topping on the cake. So we can probably have it when you have better days ahead. The same set of faculty, the moderator, etc., and have a, good cadaveric dissection for a day in Bangalore. MS Ramaya. So I think most of you would echo the same. And so moving forward, we have an interesting conference coming up in April, and I would request Dr. Umesh Srikanta to update us about this conference. I would also thank Ortho TV, especially Dr. Neeraj Bijlani and Intas Pharmaceuticals for being with us throughout this COVID times and helping us, conduct these sessions every month. Thank you. Umesh, over to you.
Yeah, thank you, Dr. Arvind. So MISSAB, ever since its inception in 2014, has been exceptionally active, and it's unfortunately only in the last year that we went the entire year without conducting any major conferences. So this time we thought better not to wait for any longer, and we thought of having an online event that is kind of a mid-year event, what we used to do as an MIS LiveCAD every year. To this time we are calling it as a MISSAB Surgical Symposium because there is no cadaver activity, obviously. And this is scheduled on the 9th and 10th of April and this year. So we welcome all of you to attend this event. So this is the entire MISSAB committee with the able guidance of the top four. That is our President, Dr. Rajkumar, Vice President, Dr. Amit, our Honorary Secretary, Dr. Arvind Kulkarni, and Joint Secretary, Dr. Alok. And with active contributions from all the EC members, so we have come up with an excellent program. We have roped in significant high number of international faculty. So then there are several highlights for this conference. We are actually telecasting live surgeries from multiple centers. There are 4 keynote lectures. There will be more than 20 surgical video lectures on techniques by eminent faculty. There are 6 live wire debates on hot topics, each of 30 minutes. 8 clinical case scenarios and panel discussions. Expert panels will be there, and these also each for 30 minutes for individual cases. There are, of course, didactic sessions, free paper sessions, and this time we are introducing something new that is called as a Young Turks Corner, which I'll be telling in more detail later on. So we already have 16 international confirmed faculty. A few more are actually, we are waiting some word from them. And we have a host of national faculty, more than around 50 to 55. So, and most of these names are known to us. All the big names in MIS surgeries are there in the conference. So the free paper submission is now already open, and I have already mentioned the important the dates that are to be noted. So the submission is ending on 10th March. So I request all of you to encourage yourselves as well as your juniors to submit free paper sessions. We have a lot of benefits for free paper sessions presenters this time. And there are several categories as well. There can be on tubular retractors, endoscopic assisted, even percutaneous needle interventions, recent advances including navigation and robotics. And these cases can be presented in two categories, that is as either a free paper presentation, that is recent advances or something like that. Also as an interesting case, like if you have an interesting case that we can showcase and we can show it to the rest of the MIS community, I think we are most welcome. There are award papers also for this. And what more, in presenting a free paper can actually make you a panelist. So this is what we have come up with for the first time this time. MISSAB always believes in promoting young surgeons, and we are encouraging young surgeons to present their work, to share their experience, to come up with all their challenges that they have faced in the initial period, and that we will give the platform for them to be represented on a bigger podium, along with expert faculty, along with other international and national faculty, to voice their opinions, to show their knowledge and to share their experience along with them. So again, Young Turk Corner is not only just that. We have a 1 hour separate session by some young spine surgeons who are going to talk on their initial challenges. What are the things that they expect out of a community like MISSAB. Of course, as I mentioned, they're there in every case discussion and debate, and free paper submission is also welcome. So I encourage all who are listening to this to register as early as possible. These are the links. Our website is actually already active. It's up and running. Free paper submission is already open. You have a separate portal to submit free paper submission on the website. And these are the contact details that I've already displayed on the screen. Thank you very much.
Thank you, Dr. Umesh. So, Dr. Arvind, you are muted.
So thank you, Gururaj, for selecting right topics and the right faculty for the right topic. As I said, it would have been fantastic if you would have moved to a cadaveric lab now immediately after this. So looking forward to looking forward to see a lot of registrations for this wonderful symposium that we are going to conduct, and again reinforcing the fact that you should yourself submit and also ask your juniors, fellows, residents to submit abstracts for these free paper sessions and also videos. So there's going to be more stress on surgical techniques in this particular conference. So encouraging you to submit surgical videos. And if you have any new ideas, you can always contact me. We have our WhatsApp group, or you can email me. Thank you. And again, thank Dr. Neeraj and Neeraj Bijlani and Ortho TV, as well as INTAS for helping us as always. Thank you.
Thank you all. Happy Valentine's Day. I think all your Valentines are waiting for you. So let's end this meeting. Okay. Bye-bye.
Thank you.
Bye. Bye.